Improvement Director here at OHA. You are at the Quality Health Outcomes Committee, otherwise known as QHOC. We are kicking off the Learning Collaborative session. I am welcomed here by a few different partners. One is Kate Wilcox. I will shortly turn it over. We do these learning collaboratives here at QHOC in the middle of the sessions. Thank you very much to Laura Krieger and our OHA Transformation Center for assisting in getting this going. We brought the Family Connects program to our QHOC meeting. Oh, geez, Kate, wasn't that like October of, I don't know, almost a year ago?
Oh, yeah.
And when we brought it back, the CCOs basically expressed so much interest in this topic that said, can we have more time on this topic, and can we have it after it's been kind of implemented a little bit? So this is that time, 1 year later, to learn how the Family Connects program is doing, and then also to also hear just kind of as it's being implemented, where and what kind of lessons there might be from that program. So I'm going to turn it over to Kate, and she'll kind of walk us through. We actually also have some partners in the community who are implementing the program. So Kate.
Thank you, Lisa. Hello, everyone. I'm Kate Wilcox. I use she, her pronouns, and I am the Maternal and Child Health Manager in the Public Health Division. And it is in our section where the Universally Offered Home Visiting Initiative lives, along with our other nurse home visiting programs. So what I thought I would do is just give you kind of a brief background as to where we are right now, and then turn it over to our Washington County partners, who are one of our early adopter sites, for really the on-the-ground story of what's been going on in Washington County over the past years, I have to say. So just to ground us all, I don't know how many people are new to this, or you've probably heard this spiel from me many times, but either way, it's always good just to anchor ourselves in what is Universally Offered Home Visiting. What is this initiative? It's an initiative to strengthen families by offering a voluntary home visit by a nurse shortly after the birth of every child. So again, it's universally offered. Families choose to participate. But why is this really important? That period of time, 3 to 4 weeks, up to the first month or two after the baby gets home, it's a really vulnerable time for both the infant and the birthing parent and the family as a whole. Integrating a new baby into any family is challenging, good challenge as well as any challenge. And most families welcome and need some support of some kind. And that's what this model does. It's also meant to connect families with services that they would like to engage with in the community. And that's the real key to this whole model, is it's about that community system of care that families can engage in and get support from. Next slide, please. So what are the goals of this project? We want to create and strengthen this community level system of care so that families can get the supports they need. Offering those supports, and as the name says, we're connecting those families to those supports. It also helps to increase the access and identify what services and supports are needed by families, so we can identify what are some of the gaps and what are we doing well. And it promotes that collaboration at that local level across the early childhood as well as home visiting systems to provide those supports. The ultimate goal is to improve health outcomes for families across the life course. Next slide, please. Okay, so we are the first state to have some statutory requirements around this model. In the 2019 session, Senate Bill 526 was passed, and it directs OHA to design and implement a voluntary universal statewide home visiting program for families of newborns up to 6 months of age. It also requires the commercial health benefit plans to offer this service to their members. As we got rolling, we realized that that part of Senate Bill 526 didn't provide enough clarity for the requirements of the commercial health benefit plans. So last session in 22, we passed, Senate Bill 1555 was passed, that clarifies the requirements of what the benefit plans are to reimburse for. Again, we are the first state to have this statute and to try to scale this up statewide. And it also includes families with adopted and fostering newborns. Next slide, please. So the model is quite elegant in its fidelity. There are just 4 pieces that are required for model fidelity. So there's a lot of flexibility within that. First of all, it must be offered to everyone, regardless of anything. This is not an eligibility criteria model. It's offered to everyone. It is offered and at no cost, no out-of-pocket costs to anyone choosing to participate. Typically, the home visit happens about 3 weeks after the baby's birth or when the baby gets home, and they are conducted by a registered nurse. This can be a 2-year associate's RN degree on up, but there are nursing assessments that happen, which is why it is a registered nurse that provides that main visit. Next slide, please. So we know that home visiting doesn't operate in a vacuum. And so these 3 program components are all very, very critical to this model. I was talking about that system of care. You have to have that system of care in the community for families to actually get referred into. And that's what community alignment is. And then you've got the home visit that helps to assess what the needs are and help families get connected to the services they want. And then, of course, we want to make sure that we have data and monitoring for program improvement and continuous quality improvement, and also understanding where there are gaps in services so that we can better understand maybe where resources might need to be developed to be able to support families. So those 3 interplay very tightly and are very important to the program. Okay, next slide. So we originally were hoping to roll this out over 3 biennia. It's now going to take us probably till the 25-27 biennium to get this statewide. We had some challenges, which I'll share in a minute, but we are in this extended phase 1, which is where we call our early adopter phase right now. Next slide, please. So we originally had 8 early adopter communities. Some paused because of COVID. One community dropped out and said they really needed to prioritize something else at the moment, and they're going to be going into another cohort down the road. And then that was Clatsop County. And then Lane County was also paused and is really interested in re-engaging at this point. So we're moving forward in 23 with re-engaging Lane. But currently, Washington County, and then Marion Polk, and then Lynn Benton Lincoln, and then Central Oregon of Deschutes, Crook, and Jefferson. And the reason that these are grouped this way is in that component, there are a couple of components that we talked about. The community alignment component is being led by the Early Learning Hub. So these multiple county sites are where the Early Learning Hub is the community lead around that part of the work. But in terms of service providers, the local public health authorities are the ones that are providing the services at this time. Next slide, please. So currently, until we got the Senate Bill 1555 passed, we were granted some permissions by the model developers to focus just on and provide services just to the Medicaid population, which goes against the model, but they wanted to give us an opportunity to get started at least. And we were starting quite small in each of those communities, so it wasn't county-wide in any of those communities. But we have completed, as of the end of September, 565 IHVs, and that's an integrated home visit. That's the main visit that happens 3 weeks after the birth of the baby. And in that visit is when the main part of the whole intervention happens. So the registered nurse does health checks for the baby and the caregiver, assesses family strengths and risks and needs, and connects the family to the resources. So also remembering that this was done over, we started seeing families in May of 2021. And so we were doing this in part via telehealth during the height of the COVID pandemic. So we are moving back to in-person home visits, but telehealth, if a family declines an in-home visit, they are offered a telehealth visit as well. So you can see the breakdown of some of the visits that we saw. Next slide, please. So our funding, our vision is to really create at the local level, sustainability through the reimbursements. Again, through commercial health benefit plans and also Medicaid reimbursements, so that there's a continuation and it's not relying on funding always from the state level. But we do have state general fund, which supports our state level staff that provides the technical support for the local implementation, contracts, some local startup funding, and provides the Medicaid match to HSD, to our Medicaid partners. It's currently in our Medicaid world carved out as a fee for service with the two-part reimbursement, one for the medical services and one for the case management services. And then in our commercial health benefit plans, we have a bundled case rate that currently is almost $1,200 per infant served. So that's inclusive. The model says that a family can have 1 to 3 visits. Most 80% of those that get the services only have the one main IHV visit. And then some families need a little bit more time, and so they would have a second and possibly a third visit. Okay, next slide, please. Okay, currently there is work in the CCO contract to participate in what's happening, even though the reimbursement is carved out. We want to make sure that CCOs are connected to this work. So there are 2 parts in your contract that talk about care coordination. So your perinatal care coordinators help to promote communication and data sharing and collaboration between the CCO programs and the local Family Connects providers. We also are requiring that CCOs participate in community alignment and planning. So that's that system of care work. And that looks a little different in every community, but that's really the core of what we're able to, that's where the benefit lies, is ensuring that those families have that system of care. And then CCOs are required to submit biannual reports on what their activities have been. Okay, next slide, please. So I talked a little bit, alluded to some of the challenges. COVID-19 really set us back about 2 years because we were using the same workforce, that nursing workforce, that needed to be diverted to the emergency response. We jumped in pretty quickly. There was a lot of energy, so we didn't have much of a planning period. So I use this analogy, and I know it's getting worn out, but we were literally building the plane as we were flying, and we continue to do that a little bit. But the COVID pause allowed us to do some planning in there. We're continuing to learn a lot from our early adopters, and that's feeding into being able to roll out subsequent cohorts more efficiently and effectively. We had some staffing capacity issues, both with our state staff as well as at the local level. And then working with commercial health plans, a little bit new for public health, so we needed to work on that. And we also are very aware that we have a nursing workforce shortage, and we have some plans about how we are going to address that going forward. Some opportunities that we have, creating a system of care for home visiting and early childhood. There's no other home visiting model that does that really emphasizes that system of care, so it will benefit everyone. And we are seeing improved coordination among home visiting models at the local level, as well as early childhood services. And we're also seeing that this really elevates the reimbursement for upstream prevention and social determinants of health, both for Medicaid and for the commercial payers. So that's the direction that we're all trying to move to, because we know that upstream work really pays off down the road. And I think that's my last slide. So at this point, I can take questions, or we can move right into Washington County's presentation and take questions at the end. Lisa, I don't know if you have any druthers one way or another.
I don't see anything yet in the chat, so we can just go straight over to Washington County.
Okay, wonderful. All right, I'm going to turn it over to Rebecca Collette, who's our lead in Washington County. And Rebecca, why don't you introduce the team that you brought with you?
Well, can you guys hear me okay?
Mm-hmm.
Okay, Yay, my headphones work. I wasn't sure. Well, thank you for having us. I'm Rebecca Collette from Washington County, and I oversee our maternal, child, and family program. And joining us today also is Annalie Aging. She's our Family Connects nursing supervisor. And we also have Peg King from Health Share, who has been on this journey with us starting before we even knew Family Connects was a thing. So she's going to share a little bit of the perspective from partnering with us as a CCO for the last many, many years. So if we could go to the next slide. Yes, so we're going to talk a little bit about overall the challenges that families face, which I'm sure most of you already know about this. A little bit of our current state. Actually, Annalie is going to go into some detail on our actual implementation, what we're learning from families, and talk a little bit about our future state, and then we'll have an opportunity to discuss future opportunities, maybe talk about some of the gaps we're noticing, and then open it up for any questions. So our Family Connects program is embedded in our maternal, child, and family program. Go ahead and go to the next slide. Thanks. And one of the reasons why Family Connects has been such a wonderful fit with our maternal, child, and family program is because we really do have an upstream focus and providing help as soon as possible. In our maternal and child family program, we have a variety of home visiting services, which includes Babies First, Cocoon. We also oversee Healthy Families. We house our Reproductive Health Coalition, and we are also co-conveners of our Early Learning Hub. So when Kate mentioned that you have a community alignment lead, which in a lot of areas that is the Early Learning Hub, and then local public health is the provider, we're both. So we're a little bit uniquely situated in how we've been able to roll out Family Connects in Washington County. Go ahead and do next slide, please. And here's Washington County for those of you that may not be familiar with what our county looks like, but we are both rural and urban. And as the darker green areas are more population dense areas. And so you can see we expand out rather far. We include Hillsborough, Beaverton, Banks, Gaston, Forest Grove, Cornelia, Sherwood. So we have a variety of communities we serve. And then the stars are our hospital systems. So our rollout of Family Connects is with our hospital systems. So 1 and 2 are our current hospital systems that we're working with, and 3 is our Kaiser Hospital that we are beginning the process of engaging now. All right, next slide. And we are also unique because we do have 3 CCOs that we partner with, which is different than our other early adopters right now. So we have Health Share that we've been working with for a really long time, Trillium and Yamhill. And then below you will see the mixture of how we expect to be reimbursed through Family Connects, or our breakdown of reimbursement. So we have private, Medicaid, self-pay, then TRICARE, and other. Annalie, did I get that one right? That was.
Yeah, it's just our
Okay.
breakdown of the different types of reimbursers. Yeah.
All right, so that I'm going to hand it over to Peg that can explain a little bit more about the challenges that families have faced.
Thanks, Rebecca. Good morning, everyone. I'm Peg King from Health Share. Thanks for having us. So in the Tri-County, Clackamas, Multnomah, Washington that Health Share serves, we have been working probably for 6 or 7 years, as Rebecca alluded to, very closely with the CCO, the 3 early learning hubs, and the 3 public health / maternal child health departments. probably 6 or 7 years to try to create a regional perinatal continuum of care so that families are able to access what they need, where they need in a more simple way, let's say. And so we come together monthly as the CCO Public Health Early Learning Hub group and work on joint projects to try to, improve outcomes for all of the families that we jointly serve. And so through different processes and different, also at the table in those meetings are WIC and the parenting education hubs. And then recently Trillium has joined the little family that we have as well. So, we've done a lot of work. The WIC programs, the early learning hubs, they all have sort of deep connections in community. And we know that these are a lot of the challenges families face. We've also learned a lot of this from our community health needs assessments that we've done, as well as recently with the new social emotional health metric that CCOs are working on. We've done a series of community conversations around the Tri-County area, and these are a lot of the issues that families are facing. And if you go to the next slide, the next slide is a little scary, and I'm not going to go over this whole thing, but it's really just this. We did a project a year or two ago where we mapped out all of the agencies or organizations that pay somebody to help families navigate. And this is what it looks like in the Tri-County. So, you have the families at the center, and you've got the medical system, you've got DHS, you've got early learning hubs and culturally specific CBOs, and they all have people in them to help families navigate. And this is obviously absurd. So we always like to say the K-12 system is a system. The early childhood system is the Wild West. Like so what we've been working on for the past 6 or 7 years, and what Family Connects is really helping with, is how can we make this simpler for families? And the main way we've been working on it is through implementing Help Me Grow in the region, which is a centralized access point to a triage menu of services and supports. And it really couples nicely with Family Connects as sort of a handoff. So once families get their 3 home visits, we can hand them off to Help Me Grow, and they don't have to know all this, or a pediatrician doesn't have to know all this. They can just refer to Help Me Grow, where they have peer family navigators that help families get what they need. So we're really excited that we've been able to sort of, all the pre-work we've been doing really fits nicely into the Family Connects model.
All right, so my name is Annalie Egging, and like I said, I'm the nurse supervisor for Washington County. And so this is just a little view of kind of what our journey has looked like with agreeing to be an early adopter in 2019 to actually working out the infrastructure of what we're going to be needing and starting the development of our community alignment in 2019. And then we actually implemented in June of 2021, which, as Kate talked about, there's a lot of delays that happen related to COVID, and that's where you see those delays for our area. And I'm going to go over this a little bit more in depth, but we started with Providence St. Vincent Medical Center in June of 21, and then we expanded to Hillsborough Medical Center in May of 22. And then our plan is to expand beyond our initial catchment areas at those 2 hospitals in January of 23 and beyond to hopefully everybody by 24. You can go to the next slide. So when we started in June of 21, as Kate talked about, we had agreements to be able to offer the visits to families that were Medicaid eligible and babies that were covered by Medicaid. And then for us, they also needed to be Washington County residents or living in Washington County, living with someone in Washington County. With both the baby having Medicaid coverage and the Washington County resident piece, we really try to have that be as loose as possible. And with the way that our referrals come from the hospitals that we were working with. And so they help us to identify the families that meet this criteria. And we have told them to be kind of loose with it as that can be. So that obviously, not obviously, that includes moms that may not have Medicaid themselves, but their baby's going to have Medicaid. And so they're the ones that help us identify that, those people. And then we started with babies that have been delivered at Providence St. Vincent Medical Center. And then we expanded to Hillsborough Medical Center, formerly Tuolity, in May of 22. It's that same criteria of the Medicaid coverage and being a Washington County resident. Next slide. So in that time, this kind of just talks through a little bit of some of the demographics around the families that we've served in terms of kind of their ages. You can see that that the majority of the women that we've been working with, or the birthing parent that we've been working with, have been between the ages of 25 and 39. We have very few super young parents, and we are kind of trying to really look at that over 40 range also. And then in terms of education level, it's really pretty well divided, almost in thirds for that less than high school diploma, or some college. And then in terms of, we do look at whether or not they're married or single or living with a partner, that kind of thing. And the majority of the families we've been working with do have two parents that have been identified that are living together. You can kind of look at some of we have about 66% of people that have identified themselves as being Hispanic or Latino, meeting that criteria. And then we do ask them all about how they identify their race. And only, sorry, I can't see my whole slide. Only about 30% identify themselves as white alone, and 57% identify themselves as having more than one race identified in their own makeup. We have about 60% of our visits have been completed in English, and actually I'm going to have you go to the next slide because we have more of a breakdown in language. So these are the different languages that have been identified with the population that we have gotten referrals from. So the left-hand column is the total population, and then the right-hand column is the percentage that we've served, that we've actually done visits with, and what language they speak. We do have we have a couple of our nurses are bilingual with Spanish and English, and so we are able to serve all of the visits in English and in Spanish in the language that the family prefers, without any interpretation. And then all of the other languages, we use an interpreter as much as possible. It's an interpreter in person, and we've been able to do that with, I think, only 1 or 2 exceptions so far. And so that is our goal, is to have, unless we're doing a virtual visit, I suppose, then they wouldn't be in person. But otherwise, we do prefer to have it be as much as feeling like a close kind of conversation as possible. And so we really prefer that interpreter be in person. Go ahead and go to the next slide. So these are some of the areas that we've kind of identified as some of the primary needs we've seen. None of these are going to be a huge surprise, I don't think, but they do kind of help us to, as has been brought up before, one of the goals of this program is really to see what the needs are from the families, and then to help to be able to speak to the community about what the needs are, and where look to the community and our partners for the ways that we might be able to help to serve these families better. Some of the things are around, a lot of it's around childcare, and along with that early learning, I think that it goes pretty closely also with other things related to income, rent, utilities, being able to have enough food and other kind of essentials for life, but it all kind of gets wrapped together with being able to, if you don't have the transportation to get to a job, to have the job, you don't have childcare to be able to attend, it all kind of wraps up together. And so there's been a big piece of it that's around childcare. And then the other piece that I think is really important to know and remember is that Family Connects is a baby-centric visit, but it really looks at the whole family and where the whole family is at. And so there's a big piece of it that is assessing the needs of any other children that are living in the home as well, because it's also looking at what the parental needs may be. And so we do find that we have that that early learning piece of it is often based on the fact that so often babies have a 2 or 3 or 4-year-old sibling that may also have need for connection. As you can imagine, and as you guys are probably experiencing in your own work, a lot of the children coming out of COVID that are in those kind of those middle years, the 2, 3, 4-year-olds, they also had very few, they had different amounts of resources that had previously been available. And so we find that there's a lot of need for helping to get them connected as well. And then there's always, we know that one of the big pieces with this program is just being able to be another layer to help to screen and support around the potential for postpartum depression and anxiety, and even just the baby blues not even, but with baby blues as well, making sure that women feel supported. And what we've found is that a lot of it is just that, is the need to have community and even just peer support. And then we obviously have seen kind of the whole range of needs, but there's a huge portion of people that just are feeling very isolated. And so just trying to figure out what does that look like to help to provide some of that space for connecting other new parents together, being able to have people know where to go if they are feeling like they need additional support, and being able to help them if they're already in that place where they're needing additional support for postpartum depression or anxiety. And then in terms of like home safety and safe sleep, we have availability of resources for that. And that's one of the things that's certainly been identified. And I would say that all of that kind of goes along with safety in general, of making sure that they actually have everything that they need for their house to be safe. And so that might mean, access to diapers and clothing and food and that kind of thing as well. So yeah, these are kind of just a list of just the basic kind of topics that we end up seeing kind of come up more and more and more. You can go to the next slide. So the way that Family Connects works is there's a long assessment. It's the visits usually end up being around an hour and a half long, and that's doing a series of different assessments, and both for the maternal health and or the delivering parent health, and then the health of the baby, but also looking at the health overall of the family and the household, that sort of thing. One of the things we do is we identify things where they may be at risk for having higher level needs. And then at that point, we do have built in the program, you actually have to do referrals to something. The family does not have to accept it. The family doesn't have to accept any piece of this. Everything is very voluntary. So they don't have to accept a visit. They can ask us to leave. That doesn't usually happen once we're there, but they can stop at any point. And that includes the referrals. So we do at certain points want to make sure that we're at least offering things, and then they can say yes or no to whether or not they want to accept them. The number in the bottom represents that number of referrals that were made based on higher level risk. And then the list next to it is kind of those things that we've had it be usually representing. So it's usually some kind of medical, like higher level medical need. We have had some behavioral health referrals, again, based on kind of postpartum depression, anxiety, and then some with the Domestic Violence Resource Center, and family justice. And that kind of just helps you to see kind of the level of need that's there. We do have quite a few people that are kind of on the edge of being at that high risk with food insecurity and housing insecurity. And we're seeing an increase in that, but a lot of times that is somewhat leveled out a little bit if they're already engaged in programs like SNAP and that kind of thing, or maybe they're already like on their way toward getting the resources, and then they don't generally need to have that. They don't have as heightened of a risk for not having food for like the next day, that kind of thing. The top number is the number of resources that we provided, and that just really represents more of the things that we identify a need. It may not be that super high risk need, but it is a need or something that might be helpful to them, helpful going forward for the next like year or two, helpful in the next week. It kind of just varies. So some of those, as was mentioned, we work pretty closely with Help Me Grow. And so they're one of our top resources that we share with pretty much every family. And with that, it can help them going forward to just have that resource of knowing somewhere that they can call. Help Me Grow, if it can really help also with referrals into stuff like Early Head Start and Healthy Families potentially as well. And then also they're a really great resource if a family has multiple needs. And we're not going to do just one referral, but they have kind of a larger list. And so that's a great place to send them for that. We do a fair amount of referrals to WIC and for SNAP as well. Again, a lot of families come to us maybe with a referral already, and we may figure out like also if they don't come and they qualify, which all of the families have been serving because they all qualify for Medicaid, qualify for WIC. And so with some of them, it's just figuring out like, why are they not using it? Is there a reason why, a way that we can be helping to get them connected? And maybe there's a reason why they don't want to, and that's fine. But we do want to give them all the opportunities and figure out if there's any way that we can be providing support to help them to be able to get that. Because sometimes the reason why people are not accessing services is just because they didn't realize how to sign up, or maybe they don't have access to the internet at all. Maybe it's a language barrier, that kind of thing. And we really try to be able to help to bridge some of those gaps. Again, Baby Blues Connection is a big one that we refer or we share with a lot of families, just to make sure that they know that there's a place they can call if anything changes, even if they're feeling pretty good or not really. We do an assessment and they're not showing any signs of postpartum depression, just making sure that people know there are other options if anything changes. And then the food bank and local food pantries is a huge one that we give people a lot. A lot of people don't realize just kind of how close they can be getting food to where they live. And so we try to connect them with that. And then Cribs for Kids is what we use for safe sleep. And we're able to give pack and plays to any family that doesn't have a safe sleep option. So far, been able to do that with every family that we've needed it for. So that's great. And then we do have, we actually started a group through the county because we found kind of a lack of a place for just being able to send people. It's currently done virtually. And it's just for different parents to get together and share kind of what's been going on with them. We also work with some of the other local groups to do referrals into them. And then there's an organization called Mommy Mentors, which we do quite a few referrals for. And that's, it's a mom-to-mom mentorship program. We can go to the next slide. So as we are looking to expand, so Washington County's catchment area has been based on hospitals. And so we will be doing our expansion, and I think my next slide talks a little bit about how we're doing our expansion, but we are expanding based on hospitals. So we will do our full populations at Hillsborough Medical Center and St. Vincent, and then expand to Kaiser or Westside Hospital. And then beyond that to all of their births that are happening with people that live in Washington County beyond that, because we just have the 3 hospitals that are actually in Washington County. All right, next slide. This is a video that we made to kind of share a little bit about the visit. So we thought we would share it with you all, and then we will go on.
This is Maren Peters' second home visit with the Collins family. New parents Rebecca and Galvin, and baby Griffin, who's almost 12 weeks old.
How has it been since the last time I've seen you? It's been a little bit, a couple weeks.
It's been good.
Maren first visited when Griffin was only 5 weeks. He's hit a lot of milestones since then, including his first baby laugh.
Okay, oh my gosh, he's trying to listen. We're funny.
Yeah.
He's happy. He likes us.
It makes more challenging moments a little bit worth it. Estoy contenta que ustedes tienen.
Family Connects is a universal nurse home visiting program that offers up to 3 visits after a baby is born.
These visits can be longer than, a clinic or a hospital visit. We actually have that time to sit down with families to talk about in depth, what are their goals? What do you need right now to be as successful as possible?
The program is evidence-based. It saves money by helping to reduce things like child abuse investigations and infant visits to the emergency department.
We're designed to be preventative. So we're able to, like I said, we check the mom's blood pressure, and if she has kind of a higher blood pressure, we're gonna be able to advise them, okay, well, you should call your doctor, you need to be seen.
The program also reduces maternal anxiety.
Just having her be like, oh, this looks really good. He's doing really well. He's gaining the right amount of weight. He's growing the right amount. I'm like, okay, then whatever it is I'm doing as mom to support this little baby is actually working.
At each visit, the nurse reminds parents about safe sleeping practices for the baby and how to keep the whole family safe.
I'm able to see if the family has working smoke detectors and carbon monoxide detectors.
What do you think?
Let's see how big you are.
The baby is also weighed and measured to make sure he's growing properly.
13 pounds, 4.2 ounces.
And the nurse teaches the family important skills to help the baby gain strength, hold up their head, and get ready to crawl.
And once we started putting those right tools in front of him, it also improved tummy time as well. So that specifically was really helpful.
There we go. So it goes like this.
If the family needs additional resources, the nurse can connect them with programs to help buy groceries, provide breastfeeding support, and to help with developmental, healthcare, and parenting resources.
Yeah, it looks great.
Family Connects is already available in early adopting counties in Oregon and will eventually be an option for all families in the state.
There's something so different about the home visit that I realized after I had it that I was like, oh, okay, this was actually really valuable.
So you can get all the institutional knowledge that you want in the world, but nothing really beats having somebody just go, you know what, you're doing it right. Here's what you can do better.
Sentirse escuchada y ayudada es algo que psicológicamente es importante. Adiós.
To learn more, go to FamilyConnectsOregon.org.
So in terms of kind of how it works or what gets covered, the nurse, as this kind of stuff, the nurse connects the family. So we are given referrals. As we've talked about, the referrals come from the hospital. There's nothing that anybody needs to do to have them happen. They're given without, because there's no criteria for needing to have them connect other than the current criteria around their insurer. But so the way that we're setting them up is that they would be automatic, essentially. There is an opt-out opportunity at the hospital level, and then we call them, and at any point they can opt out at that point, but we do call and schedule them with a nurse. And then, as we said, the visit happens, we try to have it happen around 3 weeks, somewhere between 3 and kind of 5 weeks. We do talk about different parenting and different things that may have come up with the parents previously, and just kind of things to look for going forward in terms of kind of the basics around parenting infants, and talking a little bit about child development, talking a lot about safe sleep, and other safety things and things to do with their babies as they are starting that initial development. We talk a lot about breastfeeding and feeding in general, and just kind of how that's going and what's going well, what are the ways we can be supportive. Our nurses are, one of our nurses is IBCLC trained, and then the 2 of our other ones are currently training in that way too, just to be able to provide more support around breastfeeding, as we've kind of seen the need there. And then the real goal is really bringing them back into their community, being connected with their community and resources that are already available, being connected with their medical community. This visit does not replace any of their other visits. It just is an additional one that comes to them and is a check-in. That's part of the reason why it's done at that kind of 3-week period, is it should be designed to be around, not around exactly the same time as some of their other appointments. And so we really want to be connecting them back into their healthcare if they have a need for that. And really reinforcing the ways that they communicate with their healthcare providers and their healthcare team, and making sure that they don't have any questions around that, and really helping them to work through it if they do. We also, like I said, check through basic needs and social and emotional supports, making sure that they have community, have somebody that can help them in the case of emergency, that sort of thing as well. Go to the next slide. So I think some of the successes that we've seen, like I said, we've been able to provide so far all of our visits in English and in Spanish with a nurse that speaks that same language, which has been, we've ended up having a really high percentage of visits that have been done in Spanish, and or the family would prefer to have it be in Spanish. So that's been a really encouraging thing to be able to do them all that way. We have launched a work group on our need for behavioral health referrals, or being able to connect with behavioral health referrals. And that's been done through our community alignment. We also have secured a housing navigator for our home visiting team, not just for Family Connects, but for our full home visiting team. And that's been really helpful for our nurses, especially as we move into a time where more and more people are have the potential for eviction and that kind of thing. It's one of the toughest things that a nurse home visitor can hear, is that their family is going to be without housing, or that already is without housing. And so it's just very complicated. So it's really nice to have this person in place now. And then, like I said, we're working toward lactation certification. You can go to the next slide. And then we do have our primary FQCHC, which is Virginia Garcia. They are the only clinic that we offer 100% of their deliveries. Family Connects, it's because of how high their percentage of Medicaid eligible babies are. And because they deliver at almost entirely Hillsborough Medical Center and Providence St. Vincent, they have a small percentage that don't, and then we're able to get those referrals directly from them if they do have some additional people that weren't covered by us. And that's been really, it's been a great relationship, and we're starting to be able to actually have some marketing to be able to talk a little bit more to the community prior to hearing about it. That's one of the things, and we'll bring this up as well, but that it's harder when you can't do a lot of advertising, or if people haven't heard about it, it's a brand new program. And so it's been nice to be able to have, to move forward with having at least one clinic that we're able to have some more marketing, that kind of thing. We have really strong relations with our hospital systems, which has been a huge success for us and really helped us to be able to move forward with having a smooth referral process so far. And along with that, we decided to, so Washington County had not previously been using Epic for nurse home visiting, but in the decision to go forward with Family Connects with Washington County, we also transitioned to using Ocean Epic as our own records, medical record. And so then we're also able to have access to medical records through Care Everywhere, which has been really, really helpful in having information and being able to share information as well, including what referrals we have given for families. And then also being able to kind of have access to some of the other screeners and that kind of thing that have already been done, to be able to kind of know where we're at and where maybe we should have some more concerns, that kind of thing. And we have had 98% of the families. We do a follow-up call. We do a fair amount of follow-up. So as we do referrals and that kind of thing, we do follow up about a week after we've seen the family the last time. And then if we end up needing to see them again, we can always do that as well after that phone call. But we also do a follow-up at about a month after the visit. And with that, we have ended up seeing about 98% of the families rate the visit as helpful. Keep going. These are just some of our family responses. And that happened, these are from that same month out call, which is it's not done by one of our nurses, it's done by one of our other staff members. And And some of it is like the second one that says that it was personal and the nurse made me feel like I wasn't alone. There's a lot that we see in this is a lot of women just, we serve mainly women, but a lot of them have just really validated the fact that they feel heard by these visits. And it's because, partially because of the time, partially because they are able to sit with them and hopefully feel comfortable in that experience. You can go to the next slide as well. I really like this top one where they said, even though I have 6 kids, she gave me a lot of helpful information and connected me with great resources I didn't know about. Appreciated the reminders and the fact that she kept in close contact. I think that this is a really important piece with Family Connects because it will be offered to every family as they have the next baby. And there are a lot of pieces where having your first baby is really overwhelming and has a lot to learn and that kind of thing, but it can be very overwhelming to have your 3rd baby and your 6th baby, and maybe there was a lot of time in between, that kind of thing. We've really found that it doesn't seem to make that big of a difference what number baby it is. If they've ended up having a visit, they've had new things that were shared with them and maybe just had good reminders that they just, you just are often in that time with a newborn, it's quite a blur. So that has been really encouraging to hear from different people as well. We can go on to the next slide. All right, so some of our challenges and opportunities for improvement, I would say scheduling and completing visits, and that goes along with communication about Family Connects when it's not universally offered. So I think that there's lots of different reasons that we have trouble scheduling and completing visits. A big piece of it, though, is that we're doing our scheduling through the phone and just the challenges that can happen with just being able to get a hold of people. And then we also have the challenge then of them having not heard a lot about this program yet. And so that's one of the things we're looking at and we will be kind of working toward as we move into our next phases. Our next phase is to be working with more of the wide population because we'll be expanding to commercially covered families starting in January. And it really gives us more of an opportunity to serve a larger population and being able to have more and more people receive the visits we think will be helpful as well. But those have certainly been a big piece of our challenges. And there's a continuous resources are constantly changing and whether or not they have availability, whether they have funding. And so I think just a lot of our community alignment is spent on figuring out what is available and then figuring out the ways. One of the things we've really been talking a lot about is what are the ways to be helping to everyone to know who's available for what and what are the best ways to be able to keep up with that. And so whether that's like, having spots for different programs or having funding for rent assistance, anything like that, kind of figuring out the best communication for that. Staffing has not been a huge issue for Washington County, but it has been for, I think, all of the other early adopters and certainly for some of the counties that haven't ended up being early adopters. And so that's certainly something that will need to continue. And for us, it may become more challenging going forward as well, as we need to expand fairly quickly as we expand to commercial payers, because we have such a high percentage of families that are covered by commercial insurance. And then COVID has had impacts to all home visiting and the community in general. In Washington County, we are doing mostly in-person visits, and we have been for quite a while. We do offer any family that declines an in-person visit a virtual visit, and we do have a fair number of families that take us up on that. And we can also pivot to doing, and that happens, as you can imagine, this fall. It's been happening a fair amount with just the amount of different things that are going around, that if people aren't feeling well, that we can pivot to doing a virtual visit. And then the main challenge of not being able to expand to commercial payers faster, just related to the contracts and that kind of thing with commercial insurance, but we are excited for that to hopefully be turning a corner. We can go on to the next slide.
So I see that there's lots of questions. So I think we maybe should pivot to answering questions. Is that okay, Peg? Okay, all right. I don't, does somebody want to read the questions and then we
I
can
was
try
gonna
to?
ask Rebecca, do you want me to go ahead and get?
That would be awesome. Thank you. I saw them all coming in. I
I
tried
know,
to type.
I was gonna let it go for a little longer,
Yeah.
but let me go ahead and get going on those questions.
All right.
I'm just gonna feel them out and then either Peg, Rebecca, or Amelia, you get to, you know, say not it or whoever wants to go. Okay, first question. One was if there's a breakdown, this might be for Kate, if there's a breakdown of births by private and Medicaid. So as far as the data that's being shown, if there's a breakdown on the data itself by payer.
You
Yeah,
know,
that's
Lisa,
Oh, go ahead.
sorry, Kate, just really quickly, that came from Rebecca's last slide, I believe, is what I was curious about.
It varies community by community. And as you can imagine, Washington County with Intel and Nike and some of those, and Rebecca, you can speak to this, the ratio of Medicaid to commercial payer or commercially covered lives is different. It's a different percentage. Do you want to speak to that, Rebecca?
So we're about 70% commercial insurance and about 30% Medicaid, which is one of the reasons why it's been so important for us to engage in conversations with our commercial insurance plans. But it's still nuanced even within that because there's still self-funded plans within the commercial insurance plans that I think we're going to get there. I think they're all going to be on board shortly, but we still have to work out some of those nuances over the next couple of years.
But another community like Lincoln County, it's the reverse. They've got about
Yes.
70% Medicaid and 30% insurance covered,
Yeah.
commercial. Yeah.
Thank you.
Oh, you're on mute, Lisa.
Sorry. Two questions from Kristen. How is the information shared back with pediatric offices to ensure that parents don't have to be rescreened, re-traumatized, so there's no duplication of work?
Annalie?
Yeah, so there's a couple different ways. One is that we do, so everything is available in Care Everywhere in terms of like our notes from the actual visit. And then if there's anything that's like more of a concern, then we reach out directly to the office. I hope that answers that question, but let me know if it doesn't.
Okay. If not, Kristen can put another question back in there. Thank you. And the two part of that question was, does any of the screening cover social emotional health?
Yes. Yeah. So yeah, it covers of the birthing parent, it covers, like we do the Edinburgh screen, and we also talk generally about kind of their what else they have in place too. So not just talking about like depression, anxiety, but also around like what supports they have naturally in their community. And then we also kind of around their relationships and their safety within those relationships, but also just in general, like, are they getting support from their partner, or also from maybe their family, their or friends, whoever's in the area, but kind of making sure that that's kind of where it comes back to a lot of the conversation around like getting them connected to other parents too, to be able to have that support from other people that are in the same phase of life too. So really trying to figure that out and connect them back in that way.
I would add, if anyone's familiar, which I'm guessing this might stem from the family well-being screen that does occur in some of our OB offices, that the screening is very similar. And so once we really get to a point of being universal, we'll be able to break down potentially some of the duplications that might occur in an OB's office around that intensive screening.
And we can see also what they've been screened for,
that's
like
right.
the day before or whatever. And so we do adjust based on that. So like if they've had screenings, our nurses are able to see what they've already been referred to, for one thing, and where they're already kind of being worked, like where somebody else might be working with them. But also like if they've done screenings really recently, and we will identify that and address it with them, but potentially not redo the screening. We generally don't redo a screening if it's been done really recently. And so especially if nothing's been identified as being a concern, but we'll kind of talk about like, you had this in the office, do you remember that? But we are able to see those as well.
So you're really addressing to meet kind of the members' needs based upon your review of
Yeah.
what is in their record, but only what's in the record that's available to you.
Right, that's the thing. If it's not available, then it is harder. We do talk to other families though about that and whether or not they remember having done it and kind of what did that cover, and they can decline doing it. We do talk a lot at the beginning of the visit that we ask a lot of questions, and we understand that they get asked a lot of questions at like a lot of their visits, and that they can decline doing sections of it. We don't do 100% of everything with every family because we're just not able to, and so we really try to do what is needed for that family.
Are you aware of the social emotional health statewide metric, the incentive metric work, and that coordination and collaboration?
I certainly am.
I am.
Okay, from HealthShare is.
Yes, and we've discussed it with HealthShare. We've also discussed it with Trillium. We've had less conversations with Yamhill, but yes, we're very involved in those conversations.
Thank you. I'm just going down the list. Just sorry, it feels like a little bit of a are your Spanish speaking nurses language certified by OHA? And then it's a two-parter, or do you have members sign a waiver?
They are not certified by OHA. They do. I'm not sure that they're signing a waiver that specifically speaks to that. I am not.
Our community health workers are.
Yeah, but that's only for interpretation.
Yeah.
So they're not doing, because they're not doing any interpretation, it's not the same thing, but we could look into that and having that be something that they actually sign. Yeah,
I think it's kind of like if you think about it in those touch points. So
yep.
I'm just going to put that one in your little hopper to think about as far as, just adding to the list of kind of, all of the little intricate parts about the whole visit. So next one. In Southern Oregon and other parts of Oregon, we're experiencing an RN workforce shortage. Actually, it's pretty much just kind of everywhere in the nation. Any suggestions on how this program can be implemented in these areas? That's a pretty broad loaded question, but I might as well just state it as is.
It is, and maybe I'll pick that one. So one of the advantages of this model is it requires the nurse to have a 2-year RN degree. So it doesn't ask for a BSN or a master's level or anything. So one of the things that we are looking into, and we just haven't had bandwidth yet to do this, but it's on our planning, is to see if there are interested community health workers who would like to be scholarshiped or somehow getting their 2-year RN degree and then be able to go back into their community and provide this service to families in their community. So that's something that we want to start working on, because we know there's a pipeline issue, but we also know the pipeline might be shorter for this model in that respect. There are some parts of the whole model, from recruiting to follow-up, that a community health worker can support the nurse on, but that integrated home visit has to be done by a nurse. That's really critical to the model, because there are nursing assessments that have to happen. So we are very much aware of this issue. We're trying to find ways to go forward with it, and and to support the nurses that are in the workforce.
And we've got at least one more that's on the list here. With your experience so far, do you feel that 3 visits is enough? Is it number or maybe the timing and the interaction that matters the most? Not necessarily the number of visits, but kind of like when you get there and kind of whether the mother is kind of receptive to that. You know, it's not the number of times you get there.
I will answer from my perspective, and Kate, I don't know if you have a different, but so we are finding, or Washington County already offers 3 different nurse home visiting programs. This program does not replace any of those. And we actually, so with Nurse Family Partnership, which begins always prenatally, we are not doing an additional Family Connects visit because they are already getting really, really regular nurse visits. And then with Babies First and Cocoon is never going to be prenatal. And then Babies First, we do very few prenatal. So generally, they're engaging afterwards, but we can do direct referrals into those longer term nurse home visiting programs. And so we are doing that. And so it just kind of depends. We are not finding that one of the things we're trying to figure out is the like the connecting them maybe as they're with what they actually need. So do they need a nurse long-term? Do they need maybe parenting support long-term, or do they just need resource help with getting connections made, which is a little bit more short-term. And so some of that we're able to do referrals maybe into different programs or directly into our other nurse home visiting programs. But there's certainly a percentage of families this is just absolutely not long enough for, and that I think is acknowledged by everybody. But what's nice about doing it within the counties that have nurse home visiting is being able to do that smooth transition. Our nurses are all, and I think everyone is trained this way, but for all the early adopters that they're cross-trained with Babies First so that they are able to keep a certain percentage of the families that they work with. And especially for us, we're identifying people that might be kind of in that middle of like, they need a little bit more support, but they may not need it for like years. And so often the Family Connect nurses are keeping those ones on their caseloads and continuing to work with them for a little bit longer. And then we have a community health worker that's also working on our team specifically with those families as well.
Mm-hmm. Yeah, just to kind of reframe this model is really, it's a brief intervention. You make the referrals and families are moved forward. So like Annalie was saying, if a family really needs that longer term, it's about doing the assessments and getting them into those longer term home visiting programs or whatever services they need. It's different. And some of the nurses we've heard from are like, they're struggling because they're used to these longer term visits where you develop a rapport and you're with that family for a long time. This is different. It's hello, we build rapport, we do these assessments, and we get you connected with the services that you need.
It's in the title there, Kate, missed the connect part.
Yeah.
That's the brief part, but the connecting into the longer.
Yeah, I guess my inference is that connecting to services that aren't in the home may not be as efficient or as desirable as connecting to services that are still provided in the home.
Right.
And I think, you know, Kate, with the work you and I do together in our other venue, I think we know that it's really important to have those constant and consistent touches to our folks wherever they are. And it's not always in a home, but to wherever they are. So I guess, I just would like to see this program last 2 years instead of 3 visits.
Right. Well, and that's where then beefing up the longer term home visiting programs, because if a family is at risk, like we've seen, right, it's getting them right into like a Babies First, and then they do get that really regular longer term. And so, but we also have concerns that we're going to have capacity issues with those programs too. So it starts to snowball. And it's like, okay, this is the investment that collectively we need to maybe be trying to beef up. So.
Yeah, and then my last question was just about data, Lisa. If you all had collected any data specifically on any moms that may be involved in substance use treatment during the time that you're providing this outreach, or perhaps any moms and babes that could be in treatment facilities. Are you doing home visits for women and babies there as well?
Eventually, yeah, but maybe
yeah.
not today.
We certainly can. So we have not gotten any referrals for anybody that we've ended up speaking to them while they're living in a treatment facility. That just hasn't happened for us yet. But we can do it even if the baby does not survive beyond the first, even if they're born dead, we can still do a bereavement visit for the family. The baby goes into foster care, we can offer to both the parent and the birthing parent and the foster parent if they would like a visit. So we can offer the full range. We will eventually offer to women that are incarcerated as well. It's just it just kind of depends on where, for us, it depends on where they deliver right now. And so that's a piece of it as well. And then just the timing of how long we've been doing it. We just haven't had anybody yet like that. We've had bereavement, not
yeah. Yeah, thank you. And I guess I'll just put this out there. I'm very supportive of this work. I think it's amazing. I also see that unfortunately and fortunately in your county, there's in the Washington County area, it's 69-70% commercial. I don't think this is necessarily representative of our communities that are predominantly Medicaid births, nor the level of social support that these families may already be experiencing, nor I'm hoping that as we see these outcomes and we understand that this work is really amazing, that we are able to put this work in the areas that may need it even more. Just because I think it's really essential that we're reaching out to everybody. So I'm hoping that we all become early adopters sooner than later.
We are too. Let's pray for no more pandemics and that we've got some of the other pieces in place, and we're pretty excited about 2023. We think there's going to be a lot of forward momentum for this project to really to move forward, not only in our current sites, but also adding on some additional sites and get that going so that it is statewide.
And I would just say that as we work together as early adopters, our hope and what we're working for is that we would not be this difficult for the next counties that come on. And we work together, and we want to continue to work together and be supportive, because we know that it's not going to be as easy. It's harder in some counties already that are going, but also we know that there's a lot of support that can happen by being able to kind of learn from each other. And that's something that we really are trying to start with from the beginning, is having collaborative work together to be able, because we're already finding it's very hard, and it's never going to be able to call to universal until it's actually universal. In the more urban areas, that's only more true because we have so much crossover with the way that people deliver it, whatever hospital they want to deliver at, not necessarily the hospital that they live by, and that kind of thing too. So I think it's an important piece that we're already trying to work together. And I think that that's something that, at least within the early adopters, it feels like everyone's really committed to trying to have there be that work done together to be able to move forward.
Thank you. And, for the rest of the CCOs and who are on here, you have the champions that are doing this work out in at least Washington County, and you have their contact information on the speaker's contact sheet. So as you are working with Kate in their regions across Oregon to implement this, you have Amalia, you have Rebecca, and you have their emails. So what you just heard is learn from them as you're implementing, as Kate is trying to put it in different parts of the Oregon. And you have your CCO partners on this phone call, Kate, or this webinar. So reach out and say, hey, let's get Rebecca on the phone. Let's figure out what some of the best practices that they've implemented and, you know, give them a ring. Having Rebecca speak to the regions in their community so we can learn what worked and what didn't work. That's the next step. So thank you for the great questions. The materials are obviously posted on the website. And you may get questions in the future. So thank you very much. And we will reconvene for those in the quality session at 1 o'clock. So if you want to hear about Exhibit I, come on back at 1. It's riveting. And we'll be talking about the quality strategy as well. So thank you again very much, Health Share, Washington County, Kate, much appreciated. And there's an evaluation in the chat string. Thank you very much, Laura, for dropping that in there. We do welcome feedback, especially informing other future topics and or information. So have a good lunch, everyone, and we will talk to you later.
Thanks for having us.
And
Good
this
afternoon.
Quality Health Outcomes Committee, QHOC, UPI session. I think I saw Laura come on earlier.
I'm here.
Hello.
Oh, let me do my camera. I had to switch from our remote environment to out of remote because camera doesn't work in remote.
Okay.
So now you got camera.
I don't know. Something happened to my camera earlier too. It like some pop-up thing came and said, we are now transitioning your microphone to, I don't know, some other device. So let's hope this works. We're just gonna go with it. Y'all can hear me, right?
Yeah, I can hear you perfectly.
Okay. Well, if my computer does something and it transfers to another microphone that I don't know that exists, I'm assuming someone will chat me. So we are doing QHOC this afternoon. I'm going to do a couple announcements, and then we're moving most likely the exhibit. Michelle, were you able to get a hold of Summer? Is she able to start a little earlier? Because my announcements aren't going to take a half hour.
Yes,
Thank you.
she's already on.
Oh, thank you. Hi, Summer. I was like, why did I think I was going to talk for a half hour on announcements? I don't know. Maybe y'all are going to have questions. And then at 2 o'clock, I'm going to do the Oregon Medicaid quality strategy. I actually have to break away. So if Summer doesn't go very long, Laura's going to do an interpretive dance. But I will come back at 2. So Laura, you do something until 2, but I'll come back at 2.
You got it.
But I do have a quality strategy presentation that I'll talk about that relate to the recently approved waiver for Chanel, who is at Cascade Health Alliance. Y'all have heard me talk a little bit about what's coming. But for the rest of y'all, you haven't heard about what's coming as far as the Oregon Medicaid quality strategy. So I know a few of you want to hear about that. So I will talk about that. But I do have something a little bit between 1:30 and 2. So hang tight. Or take a really nice, lovely fall fresh air walk. Okay, a couple announcements. If you didn't hear from me this morning, I am going to be sending out the 2023 meeting series. So if you don't recall, we have CCO point of contact for physical health, behavioral health, oral health, and quality. So those 4, I actually have a list per CCO. I'm going to send each CCO the list of people, and I'll say, here's the people I have, but I'm not sending it to everybody because it's a really long list. And I'll say, CCO, you are the point of contact for your CCO. Here's the list that I have for all. I'll use Laura for example for all care. So Laura with Kelly as the medical person. I can't remember who the behavioral health person, and the other Laura for oral health. You 3 and the one behavioral health person I can't remember right now in my head. We'll get an email and it'll say, here's everybody for all care that is on the QHOC invitee list. Please go do your list, review, and tell me who should stay on and who should not. And then you send it back to me. I'll copy your innovator agent better, and someone needs to get back to me whether the list is right or not right. And you're, by the way, showing your email. Michelle. And then.
I know I'm fixing it.
No problem. And then someone from All Care, one of the four, will tell me, Lisa, here's the list. Please keep everybody on it, or please remove this one person, or please add this person, remove this person. And then I will send out the 2023 Zoom appointments, or the actual Outlook appointments with all the Zoom meeting links. I scheduled all the Zoom. The other thing I did do is I scheduled it so you don't need to register. So the whole, yeah, you're all welcome. That's a little surprise. There's one link. Everybody can just join it. Everybody can join the little QHOC party without having to register. I don't know how I did it, but I know I did it. So yay for that. So there'll just be one link. So CCO point of contact, you'll get that email. You have to review your list. You're only gonna get like maybe a week. I don't know, I'm gonna do it sometime before Thanksgiving, so you get a week. And then you clean up your list. It's not the one all be all, and you can always add people, but I'm gonna send out the 2023 probably right before the Thanksgiving holiday. Any questions about that? Okay, the other thing I announced this morning was the December meeting is on. Sometimes we cancel December. We usually cancel because of weather, but we're virtual, so that's kind of not really an issue right now. We are going to hold December's meeting. We're going to have a HERC update. We will also have an EPSDT update in light that there's a lot of changes coming for January. So there'll be a HERC update and an EPSDT update. And then as I've spoken with the chairs, Laura being your quality chair, the other Laura being your oral health chair, and Doug and Jeannie being your medical chairs, we're going to take the other time of that being don't want to call it a retreat, but we're calling it a planning session for 2023. So I will tee up what most likely will be breakout sessions and small groups where we'll talk about what we want out of 2023. It won't be I could do what we usually done, which is, hey, everybody review the charter, and then nobody gets back to me on the charter, which is why we're changing it up. Laura knows that. So we're not going to do that because that, wasn't the most effective, fun conversation. So we're going to do some planning, and you all, if this is a collaborative meeting, as in OHA and CCOs and partners. So if you want to be part of this meeting, you all are going to tell me how you want to engage in this meeting. And that will be in December. And the chairs are looking for your feedback in that as well. So they thought this was a great idea as well. And they want to hear your voice. And we're going to use part of December's meeting for that process. Then what will happen is the chairs and I will meet, and then we'll start to map a work plan out for 2023. Any questions on that? Okay, then I will start to map out our December, I guess you could call it a retreat and call it planning session. It most likely will be kind of again to the 12:30, and then most likely Laura and I will, unless something drastically comes up, we will not have an afternoon session. It's my guess. But we'll talk about it at our chair agenda setting call and go from there. Laura, do you have anything to add?
No, you're covering it nicely.
Okay, I will take care of the other announcements when I get back at 2. You want to advance the slide? Oh, I guess I'll just take care of it now. The TQS frequently asked question, RealD and PCP member enrollment. When will the RealD SOGI flat files be available? Well, I'm just going to read because I'm just the spokesperson here. Between January and June 2023. When will CCOs be notified when they need to submit a project for their PCPCH member enrollment? So if you don't recall, the PCPCH member enrollment component, the criteria is if you meet a specific enrollment threshold, you don't need to actually do a member enrollment project. So then it's like, when will you know if you need to? The dashboards of non-incentivized metrics is published sometime in November 2022. CCOs will be notified when they need to submit a project. The OHA TQS team will notify CCOs whether they need to submit a project based upon those dashboards. The actual dashboards will be posted through your normal CCO metrics webpage. Can CCOs use a self-reported data for PCPCH enrollment? Not for 2023 TQS. CCO's self-reported data for 2022 won't be validated by OHA in time for 2023 TQS submissions, and so therefore we're sticking with the 2021 OHA validated data, and it really is just about timing. So sorry. There's the answer. I think we also shared this during a TQS office hours or something like that, so we just wanted to make sure we got it in a broader setting, but it came up during office hours, TQS office hours. Those are the key TQS wide questions that are more relevant for y'all. So any questions about that, let me know or put it in the chat string or bring it back up at the 2 o'clock hour. I'm going to turn it over to Summer. And then, like I said, Laura, I'll be right back at 2 with the quality strategy and any other questions y'all have.
Okay.
Thanks.
Hello, good afternoon. Can you hear me okay?
Yes, we can. Thank you, Summer.
Great. Okay, good afternoon. So we are here today. I'm joined by my colleagues. First of all, I'm Summer Cox with the CCO Quality Assurance and Contract Oversight Unit. And I'm joined by my colleagues, John Levere and Jonathan Uriarte Lopez. And we're just going to go through the Exhibit I quarterly report changes that are coming your way. Next slide, please.
Okay, and this is where I get to take over. Hey, Summer, you can hear me, right?
Yes, sounds
Okay.
good. Go ahead, Johnny.
Okay. All right. My name is Jonathan Uriarte Lopez, but just call me Johnny. It's the name I prefer. And I'm going to be going over the background and context. So the QA team here, we took responsibility for the analysis of the Exhibit I reporting back in Q1 of 2021. And my colleague, me and my team here, we've been doing a lot of work to try to improve the process, whether it be updating templates, updating code, so we can try to streamline and improve the process for reporting and data analysis. So that way we can present the information in a much more organized fashion and also be able to look at other aspects of the data that we didn't consider before. And this is all done in order to implement the requirements for the Oregon House Bill 2517. We still need to collect data on the CCO prior authorizations, so we could try to be able to come into compliance with those new requirements. Now, we do plan on implementing these changes, but we're going to do it more in batch. That way we don't have a little change this quarter, a little change this quarter. We're going to introduce all these changes all at once, so that way we can all stay on the same page. Back to you, Summer.
Okay, next slide. So first up, we're going to talk about grievance and appeal log revisions. So to the log, we're going to be adding a prior authorization log tab due to that House bill and the need to collect the prior authorization information. Along those same lines, we're going to add a PAID column to the NOABD and appeals tabs. We're also going to add a claims ID column to the NOABD tab so that we can separate. Sometimes we receive a batch of claims that come in on the same NOABD, and we need to be able to separate those. So we're going to be asking you for a claims ID. Even if you have several on the same NOABD, we want to see those separated out by line. Lastly, on the G&A log, we're going to add the date and time of appeal overturn columns and date and time of member provider notification columns to the appeals tab. And at the end of our presentation, if we have time, we can jump over to the new template so we can walk through those. Next slide, please.
I think this is mine. Hi, everyone. My name is John Levere. I'm a compliance data analyst with OHA. We are also making a lot of changes to streamline the reporting. Previously, it was a macro Excel spreadsheet that was very large in file size and had like several different tabs and macros and just a lot of fluff that we thought we could just like get rid of to speed up and improve our storage capacity. And some of the things that we did to improve, we removed the tabs that had the codes and categories kind of like listed out, and we're just going to keep that in a separate spreadsheet, so that way you can still have it to refer to it, but you don't need, it won't be like part of the report that you send to us because it's just kind of duplicative that way. We also removed action category, subcategory, service type columns from the appeal tab. And so using the IDs that Summer mentioned in the previous slide, we'll be able to track PA from beginning to like NOABD to appeal using that ID. And so because of that, we don't need the duplicative columns on the other tabs. We can just refer to the PA ID that it's referencing. We also removed any columns that had like Excel formulas or calculations because we're going to be doing the analysis on the back end using the files that you submit to us. And again, those were kind of just creating more trouble than like help. And we got that feedback from the CCOs as well, that they were more confusing than necessary and they didn't really use them all that much. And then lastly, we are removing the grievance log outstanding and appeal log outstanding tabs. And those were just kind of duplicative as well. They were meant to like move any kind of outstanding grievances from one tab to another tab, but we're just going to be able to account for that in the files themselves.
Okay, next, the grievance system report revisions, and that's the Word document that has the tables and the narrative. So to this report template, we're adding a prior authorization section, a table and narrative. We're also adding some REAL-D narrative questions to the grievance and appeal sections. Next slide, please.
Powering off.
And to the instructions, of course, we're going to be adding prior authorization sections, so you know what to cut on those new prior authorization sections and tables. And then we're going to also refer to the codes and categories list that were removed from the GNA log. We now have a new document, as John referred to, and it's called Exhibit or Grievance System Code Tables. And so the instructions will let you know when you need to refer to that table to pull your code and enter it in. And we can show an example of that here soon. Another that we want to talk about is adding some new NOABD subcategories to really hone in on the reason for denial. So some of the current examples are on the left side there, what we have on the current template, like treatment is not a covered service, or it requires PA and was not pre-authorized, or the service is not medically appropriate. Now we've heard questions and feedback from multiple CCOs, and so we're definitely going to be adding to this subcategory area so that we can really have a more robust list of denial reasons. Some of the new examples are going to include things like record is missing information necessary for MCE to approve the requested service, or treatment is below the funding line with a prioritized list, or even duplicate claim. And we would definitely like to hear some additional feedback from you all if you have additional ideas for specific denial reasons that we haven't been capturing thus far. Lastly, on the instructions, we're going to be reformatting the instructions. So the look and feel is going to be just a little different, where we're going to have tables that are going to outline your data input instructions. So it's a cleaner look and feel. Next slide, please. Okay, so all of these revised report templates and instructions are going to be posted by tomorrow. I think they might already be up. And the changes are effective for the Q1 2023 reporting period. That one is due May 15th, 2023. So we're giving you plenty of time to implement these changes. And if you have comments, questions, or feedback, please send us an email to our HSD Quality Assurance email there on the screen. Any feedback you provide will be taken into consideration, especially on those NOABD subcategories. Next slide. Okay, that concludes the changes. What questions do you all have?
So does anybody at all have questions? Because now's a great time to ask. I know last time we talked about diagnoses or diagnosis codes on the authorization one. Is that still going to be something that we will need to be providing?
Yes, Laura, we are asking for diagnoses and procedure codes.
Okay,
if there isn't a diagnosis that comes in for whatever reason, say it's a dental PA, then you wouldn't put anything in that field.
Okay, and is it just the primary diagnosis or all diagnosis codes associated with the authorization or claim?
All diagnoses codes that are associated.
Okay, it looks like Ann Warner has a question. Ann, you want to go ahead?
Yeah, we had a couple of questions, and I don't know if you may want our questions by email too. On the NOABD tab, there's a place where it's asking for the date the service was provided for all claims NOABDs. Is that supposed to be the date the service was provided or the date we received the request to pay the claim?
The date the service was provided, not the date that you received the claim.
Okay. So in order to do the calculations that are needed for the written report, we'll need to do all of that ourselves and collect that data separately then and create our own reporting, because we don't, with all the summary tables now removed from the report, we used to use those to fill out the summary tables in the written report. After we combined all of our data from our, delegated providers. I guess I don't understand why it's the date the service provided for the claim and not the date the service requested, because that would tell us the timeliness of the NOABD.
John or Johnny, do either of you have any input on this one? I'm trying to remember the conversation we had internally as to why we're only doing it for date services provided and not otherwise. And I think it's because we're not measuring the timeliness from the time that you receive the claim to the time that you send out the NOABD. That's
So you're
not a measurement.
Timeliness.
Not for a claim. For a PA, yes, we are, but not for a claim.
But we're supposed to leave it blank for a PA. There's not a place to put in the time of a request to the time of decision for a PA.
The PA, now there's a new PA log that will capture the date of the request.
But it
So
doesn't capture the date of the decision.
But the NOABD log, I think, does. It captures date of NOABD.
Okay, so PAs, you're only concerned about timeliness for denied PAs.
Right. We're not capturing your timeliness otherwise. Not in this log.
Okay.
Not here.
So what is the purpose of the date the service received for a claim versus the date of the NOABD?
I think it's because we're not capturing the dates for the claims anywhere else. While we are capturing a date for a PA in the PA log, we didn't have a date column for the claims anywhere else. So that's why that column exists.
But the date of the service is different from the date of the claim.
Mhm.
We know.
Okay. I guess I don't understand what I'm asking. What will it be used for? How is that useful information?
I think it's just another identifier to help identify that claim.
Okay.
We have a couple of questions that came in. The first one is, will we leave it blank if it is a PA request? And I believe you just said yes. Is that correct?
That's correct.
Can I jump
The
in
date
here?
service.
Yes.
So we have instructions for every field posted on the CCO contract forms page. And I think it would be better to receive these questions and answer them in writing and update the instructions as opposed to verbally in this meeting. So I think if there's any feedback on the instructions, sending that to us via email would be more effective. And then we can take it back to our team, discuss internally, update, and answer that way.
Okay.
Thank you. Thank you. Because then we'll be able to refer and discuss internally.
Okay. Well, with that said, I guess we're done with this presentation. Unless you guys have something additional that you guys want to provide or demonstrate or inform. It's either that or else I'm doing interpretive dancing for 30 minutes.
Looks like suggestions for NOABD subcategories. That is a discussion that we would definitely like to have. If anyone has suggestions, we would definitely take those.
Do you want those by email as well with our questions, or are you open to suggestions now?
Either, both. Yeah, whichever.
Because I know over here at All Care, we have a crosswalk between rules and denial reasons, adjudication codes and stuff, that we could probably provide you a list of what we do just based on adjudication code crosswalk to an OAR specific rule. Does any other CCOs have any type of tools that would be useful for this group?
I think we have a similar kind of crosswalk that we use. And we had a couple of ones that we weren't sure where they should go in the current list. So should we send those in by email with our questions? Or do you want to talk through them now?
I would say whatever we talk through now, definitely make sure that we follow up with an email. So that way we have it in writing too. But yeah, we're happy to hear your suggestions now. So
okay,
Laura doesn't have to dance.
We'll save Laura. We had a question around, so if a claim has a provider issue that's preventing payment, like a provider that doesn't have a valid DMAP ID or the NPI number doesn't match. That was one we weren't sure where you would recommend doing that, or if that's an area that you'd like to see separated out.
So is this a claim that you're unable to make a decision on because you're missing information?
Provider information is incorrect, or we don't have a DMAP ID for payment.
And in that case, are you going to be denying that claim because you don't have that DMAP ID?
Mm-hmm.
Yeah, so we would want to see that reported here.
Yeah, so I wasn't sure if that was something would go under number 6, the record is missing information necessary to approve the requested service. or if that's something that would be its own, should be a different category.
Let me pull it up. I think number 6 would work well, unless you want, you know, something a little more detailed, then we'd be happy to look at that suggestion as well. But number 6, I think, would work just fine for that.
Okay.
This is Alexis from IHN. I was just wondering about claims that are denied for DMAP. Is that not considered a clean claim then? Because there's a definition of clean claim that all those elements has to be met before we deny it.
This is Veronica, QA manager. I was actually also just thinking the exact same thing, Alexis, that I think the instance that's being described, I believe it was Anna, would not be considered a clean claim because there's missing information from the provider that needs to be obtained in order to process the claim. So I actually don't know that it would fall into our log until that additional information is obtained from the provider. So we might need to take this one and think through it a little bit.
So one of the ones that we have denied for, and it's on the medication side, is step therapy. So our formulary has step therapy in it, and we may deny a medication because they have not tried the step drugs. Is there a specific category you would want those in? Oh, that would be 13. I'm seeing it now. Sorry.
I was just about to say that. Yes, you found it. And that's a recent addition.
Yes, and I like that because that's one of ours, or it's a drug that doesn't meet our internal PA criteria, and so it gets denied that way. Member eligibility, treatment. Sorry, I'm just kind of going over some of the categories.
And it looks like Nick has a hand up.
Yeah, thank you. And you guys might have already touched on this and I just didn't catch it, but is there a turnaround expectation on the claims NOABDs? Or is it only the PA NOABDs where there's the turnaround time exception? Because again, that's I think where it gets back to the receive date versus service date versus the adjudication date. So is there a standard there that will be being looked at for claims denials, claims NOABDs?
Currently, no. We just had this talk internally. So there is the requirement on the PA side, but not as much on the claim side.
Okay.
And Summer, is that because the member has already received the services?
I'm not an expert in this field, guys. I wish Tanya was here. She could better explain it to you. I just remember that we had, and that was the takeaway.
This is Veronica. That is correct. That's my understanding, that because the service has already been rendered, there is no additional time frame in terms of when that claim needs to be responded to. Obviously, there are some additional time frames between CCO and provider, but that's kind of separate from I think the issue that we're discussing here.
Okay, any other questions or thoughts on the new templates?
I just one more, and I just want to make sure that I'm clear. So on the PA log, the NOABD log, and the appeal log, is column A the ID? Should it be consistent across all three so that you can see PA 1, 2, 3, 4, 5 is also NOABD 1, 2, 3, 4, 5, and also appeal 1, 2, 3, 4, 5? Or could these all be a different number? Because our PAs might be 1 and NOBDs, but our appeal could be a different number.
But your appeal could be a different number. Yeah, no, that makes sense. We don't have all of them on all logs because we tried to avoid duplicity where we could.
Okay.
That's the AID on the appeal log.
Yeah, because we would, based on the modules and stuff that we use in our core system, would determine what that number is. And the prior auth and referral may have 1, but then when it gets to the appeal and it gets in the appeal queue and is captured there, it's a totally different number.
So your PA ID changes from the time it's a PA to the time it's an appeal?
No, when the appeal comes in, the way our systems capture it, it does assign it a different number, but it links the two together. So you put in the appeal and you link it to, this is the authorization number that this is attached to. So I wanted to make sure that we're putting the correct number you want on the appeal log. Do you want it that authorization number so you can go back and see the original authorization? Or do you want it the same as in our system? Because we could do it either way. I just want to start doing it the right way from the beginning.
And right now, it looks like we only have the NOABD ID on the appeal log. So
Okay.
no PID needed here. So for you, you're just going to enter that initial PA ID on the PA log. And I think that's all we need. John, correct me if I'm wrong, but I think that's I think that's what we need.
I believe the reason that we have the NOABD ID on the appeal log is we want to know which NOABD is being appealed.
Okay.
And then not all NOABDs are for PAs. There's also claim denials. And so that's why we had to introduce the NOABD ID and not just have a PA ID across the board, because some NOABDs are for claims and some are for multiple, which I see a question in the chat related to.
Just a separate line for each claim for that question in chat, Anna. Not a separate line for each claim line, because that would get crazy.
Yes, it would.
Yes, it would. Okay, but so if we have, 5 claims that are all rolled up into one NOABD, that NOABD would be listed 5 times.
That's right.
Once for each claim that's included.
Yes.
And it would get the same NOABD ID.
Yes.
So that would just be one NOABD, multiple lines.
Yeah. That way we get the true number of claims that are being denied, which we've been missing to date. It's hard to see the way that we've been collecting it.
Okay.
Laura, this is Dana at Willamette. Can you hear me?
Yes.
I can hear you.
Okay, good. So just wanted to ask also, is the preference that if something doesn't apply, that we just leave that row or that section blank?
Blank.
Or just to write in it?
No, leave it blank. And again, the instruction document will guide you. Not everything can be left blank, but there are quite a few out there that can be. So take a look at that instruction document, and if it can be, it'll give you a no value, and it'll say no value equals blank. Please do not enter NA and any form of NA or other way to say that. No other data in there, please.
Okay, so these just got posted to the website, to the CCO forms website?
And then,
That's right.
and you're saying these are final for next year. Is there an opportunity again to look at these once we've had a chance to go over them and ask questions, or is this kind of it?
Yeah, no, we still have opportunity to make changes as needed, especially like the NOABD categories we were talking about earlier. Definitely want to get your feedback.
Yeah, okay, good. Because they don't say draft. I was just confirming that was the case. Thank you.
Okay.
And the reason why we're posting them, I'm just gonna say the reason we're posting them this early is because we're asking you to start collecting this information effective 1/1/2023.
This is Veronica. I just wanted to clarify that if there are additional changes that are made based on your review and feedback, that we would not restart the 90-day clock for the guidance to be updated and then reposted. So basically, we would still have an effective date of Q1 2023. So for the report that is due in May of 2023 to us.
Thank you, Veronica, for that clarification. Anna?
Hi, I have another question. For the number of PAs overturned, is that just PAs that are overturned through a member appeal process, or would that include some that are maybe like a peer-to-peer process? Just providers where the member has not been a party to that request?
Good question.
I think both, but anyone on my team, correct me if I'm wrong, because ultimately we're trying to capture the number of appeals that are overturned, no matter what the scenario is.
But if it doesn't come in as a form of an appeal, would you still want to know? Because a provider only has an appeal if they've been provided consent in writing by the member, blah, blah, blah. If a doctor submits just additional chart notes and we look at them and overturn it based on the documentation maybe we didn't get originally, it's not an appeal, but we've overturned it because now we have supporting documentation for the medical appropriateness for the service.
Yeah, exactly.
Yeah. And we were looking for a strictly appeal overturned, but please submit a question because I want to take that one back and consider that.
Yeah, because we do what we call it, we reopen the denied auth if a provider just gives us new chart notes or they call into a peer-to-peer with one of our medical record or medical directors. It doesn't go because we're still leaving that appeal process intact for the member because they haven't appointed anybody. So currently those aren't being captured. I mean, we can capture them internally, but they're not getting reported.
Right. Okay, interesting scenario. Thank you for pointing that one out.
Okay, so we have another question in the chat. So it is, okay, so it is denials overturned on appeal, not total number of denials overturned. And I think they're getting back to us on that one.
Yeah, right now, the way our log is set up is it's just for appeals.
Okay.
Just for the appeals.
Anyone else? I want to thank you for the great discussions today. It's really, I think it's helped some of us, and I think it also gave you guys some insight also as to some of the work that's being done at the CCO level in the region area of authorizations. So thank you.
Thank you for time.
Yeah, you're welcome. And then also for everyone on the call, Cheryl Henning sent out the new forms and everything on Thursday afternoon. So check your emails if you're on her distribution list. So in case you don't find them on the website, they were sent there as well. One last question I have for Summer is, where do you want us to email our questions to? Do you want us to just filter everything to Lisa and she will send them on to you? Or is there a direct email address you would like us to utilize?
We have a direct email address on the slideshow, the second one to the last, and that's hsd.qualityassurance@odhsoha.oregon.gov.
Awesome. Thank you so much.
We'll put it in the chat.
Awesome. Great. Okay.
All right. Thank you all.
Thank you, guys. So we have about 15 minutes before Lisa comes back, which is fine. I just have a couple of things to talk to you guys about, or one thing to talk about for like the December meeting is start thinking about topics you want us to cover next year during our afternoon QHOC sessions. Has there been anything that has been coming up over the year that you want us to spend some time and focus on? Maybe one of the ones I thought about is we're all getting ready to start writing our QHOCs and the summary of how we did over the year on our quality improvement plans and all of that. So if there's anything you guys want to have discussed next year in 2023, if you can let us know, that would be great, or at least start thinking about it for that December meeting. And you guys are all so quiet. Okay, well, that took a whole minute. Yeah.
It's quiet. Too quiet.
It is very quiet. And I'm having, so when I'm at home, I have to flip between our remote session and not outside of remote to do Zoom. And so I keep flipping back and forth trying to see what's coming up next. So, okay. Are you guys all getting ready for 2023?
We got high hopes for 2023.
What do you guys think about, we haven't seen each other in a few years except for on Zoom. Have you enjoyed Zoom?
Laura, this is Dana with Willamette, and I am just curious whether OHA has said anything to you about opening the building for in-person meetings or starting to have in-person meetings again for this meeting or for others?
We kind of talked about it briefly, and it's part of what we want to discuss further, I believe, in on that December meeting. It's hard to do. Lisa was concerned about doing a hybrid because of the interaction between those on the screen versus those in the room. And I attended one of our CAC, our council meetings the other night, and we did our first hybrid where it was half in person, half on Zoom still. And then that was done the month before. And we asked, how did that go? And we actually got really positive response back. But we use a camera that every time it's set up in the room, so every time somebody speaks, it pans to that person. And so they're up on the screen as well. So it looks like it feels more inclusive. So everybody is almost seeing the same thing. And it just feels like everybody's still kind of in a Zoom type setting, but some people are in the room. But they liked it. Are you guys experiencing or had any experience with like hybrid meetings that are going well or not going well?
I think honestly, the efficiency that's come from all digital meetings to not have travel time as a necessary component of in-person has definitely kind of changed the landscape quite a bit as far as what's considered best utility because of the time frames involved. It's easier to back-to-back meetings in this all digital age.
Yes. And I'm finding, and OHA has started doing or began this year with doing that 5 minutes after the hour that they start. And it actually has helped me out so much because it does give you that just a breath before jumping from one Zoom going to the next Zoom. And I'm technically normally I'm in the office. So it's for me, it's either running from Zoom to Zoom or actually running from Zoom to in-person meeting.
Got to get those
Laura,
steps
this
in
is
somehow.
Yeah, and I mean, pre-pandemic, our goal was to have meetings that happen on the same day, so that people who are traveling are only having to do it once, and then the meetings are grouped, during the third week of the month. And QPI, QHOC's always been the second Monday, but other meetings have been combined. So, I would say that it's not like we're asking people to drive to Salem for one 2-hour meeting and that's it. So,
yeah.
But again, it needs OHA coordination. So I guess that's what I'm saying is like, I feel like if we are going to do this at all for any of the meetings, we got to do it for all of them.
I agree. I'm just taking notes. Does anyone else have any input? Okay, well, we have about 8 minutes before Lisa comes back. Does everybody just want to take a little break until 2 o'clock? Okay, I got a thumbs up. So let's go ahead and just everybody go on mute and we'll come back in just a few minutes. Welcome back, Lisa.
Hello.
Wait a minute. Can you hear me?
Yes. Yes, and your picture comes and goes.
You remember technology wasn't working? I said possibly.
Okay, now your audio is gone.
Oh, geez.
Oh, we heard oh geez.
Hello?
Yeah.
Hello?
Hello?
Let's see if it stays. You heard me say, oh, geez. I'm like hesitant to talk. Okay, we're gonna give it a go and we're gonna hope it stays. If it doesn't, give me a minute while I have to transition to a phone, but let's just not touch too much on my phone, my computer. Thank you for being patient while I came back. Connection unstable. I know. It was fine up until I came back into the Zoom land. Okay, so Lisa Bowie, before we go back into the quality strategy presentation, if you wouldn't go back one slide, Michelle, please. Were there any questions left over from TQS or PIPs or anything else at all?
Hey Lisa, this is Cassandra from Pacific Source. I have a question around the SUD email that was sent out to folks about the statewide PIP timeline for reporting. So could you clarify for us, do CCOs need to have a Q1 or Q2 PIP in 2023 for SUD, or is it going to be similar to like the schedule for the behavioral health integration PIP, where we did a validation in the summer and then we had a Q3 report?
We will be instituting quarterly reporting for IET, SUD, statewide PIP, but we don't know when yet because we're still working on the baseline validation year. So you will have ample notice. So in other words, no Q1 quarterly SUD reporting.
Okay, thanks. That's it.
And I will give an update at a QHOC and or email you all when that will be. So you'll have more than a quarter advance notice at the latest. So I am waiting to find out who the analyst will be for the SUD IET part of the statewide PIP reporting. Michelle, would you mind going back a slide just so people know that we haven't started the, thank you, the quality strategy. So for the statewide PIP SUD metric, you all know IET is obviously incentive measure. It has been, right? And that reporting comes out through your CCO incentive metric dashboard, I think on a quarterly basis. And that reporting, I believe, has 18 and over, and there's a slight variation on what we did for the statewide PIP, because I think we went down to 12-year-olds, maybe 13-year-olds, I think 12. And then the incentive measure is 18, from an age stratification. So the CCO incentive measure is 18 and over, statewide PIP is 12 and over, right? So obviously, discrepancy. The other discrepancy is the IET statewide PIP. We're going to give you the data monthly, not quarterly. So, but we're using the same HEDIS specification. So that's not different, right? Using the same specifications, but the stratification, age stratification is different. Incentive is 18 and over, PIP is 12 and over. The reporting frequency, quarterly, monthly, right? I'm waiting to find out who is the analyst that's going to be assigned to the PIP side. Because I believe I'm being assigned a specific person for the PIP side because it's a monthly one versus a quarterly. Once I find that out, the two people will work very closely because it's the same HEDIS specifications that they'll be pulling from. It's that part of it, and we obviously want it to be congruent. So that part will be 100% HEDIS specs because we don't want any of that issues with NCQA. Once I find out who the analyst is, so you all have been working, if you haven't already connected with Jason on the mental health access, that mental health access PIP is an analyst named Jason. And if you have any issues, you literally say, Lisa, who do I connect? And I connect you with Jason. Well, I'm trying to figure out who the analyst will be for IET statewide PIP. And then they'll run it for the baseline year. And then we'll literally connect your analyst with our analyst. And if there's any questions, analysts talk to analysts. And then we'll also know when we're releasing the baseline data for the whole baseline year. And then it will be released through, again, the CCO metrics dashboard distribution SFTP site. And then we'll say, okay, you have your baseline year. Now is when the next quarterly report will be due from interventions based upon the time, your clock has started. But I won't know that until the analyst's been assigned and that they've implemented the most recent HEDIS specs. And so once that is established, I will report back to you all. Does that make sense?
Yes.
And we want to make sure we obviously update, we want to make sure we implement to the new HEDIS specs, and we want to make sure we want to make sure that I have I do want to, like, I don't want to transition analysts. So I'm trying to wait for one analyst that's going to hold it for the whole time. That's really what I believe I'm waiting for. So I'll let you know as soon as I get that name. Frank Wu, who I believe you are familiar with a lot of the CCO incentive measures, will be helping with said analyst, but again, he's not going to be the one to own this particular one from a market perspective. And then I'll let you know when the quarterly starts. And then it will be, like you said, Cassandra, it will be very similar to the mental health. You'll be on a quarterly schedule, except for July quarterly report will be your annual validation. You don't need to do an annual and a quarterly. Your quarterly is waived for that quarter because you're doing annual validation. And I'll remind you at that QHOC.
Thanks, Lisa.
And that's all now, because it's like been almost 2 years. Oh my gosh, it's been 2 years of the pandemic. Where we're now refreshed because this all happened when we were doing it during opioids, and then everyone's like, wait, we do this? Yes. But I totally appreciate that we did go through a pandemic and it got waived during the pandemic. So. Okay. Michelle, if you wouldn't go back, or if you wouldn't mind going back to the title slide for the presentation, I'll get right into it. Thank you so much, Michelle. Okay, I'm going to cover Oregon's Medicaid quality strategy. I'm going to cover a little bit of purpose, so some of this might be review for some of you. I'll give a brief overview of Medicaid, brief overview on quality just in general. You all are quality folks, so probably preaching to the choir on that part. And then specifically Oregon's Medicaid quality strategy, what it is, what's in it right now, and kind of where it's going. Next slide. So triple aim, and some of you might have heard the quadruple aim. It's coming and kind of there, but I'm going to still go with the triple aim where Oregon's at. Better care for individuals, better health for populations, and lower costs. Why we do this work. You've all heard from me, very mission driven kind of individual, but it is about, and I always look outside my window. I sit by a window. But it's really about the members and the community you serve. So the work we do, the work I do, the work why I'm here is really for, and I look outside, for the Oregonians, for my neighbors, for my family, for our community. Next slide. One way Oregon moves towards those triple aim is through Medicaid, and it is a significant lever that obviously the Oregon Health Authority has. And so what I'm speaking to today is specifically obviously Medicaid, and you all are one key partners in that, as in the CCO. So this is the Quality Health Outcome Committee for CCOs. So this is the Medicaid arm of that. Let's go to the next slide. Oregon Medicaid landscape. So by the numbers, approximately 1,442,803 as of November 1. 16 Medicaid plans. You all know that. 1 fee-for-service or open card and 8 innovator agents. Next slide. Some of you might have seen this. It's a little bit been around since I've been around. But this is how I view kind of some of our quality elements. So Healthier Oregon, otherwise known as the State Health Improvement Plan, otherwise known as the SHIP, kind of the population health at the top. And then one below that is Community Health Improvement, otherwise known as Community Health Assessments. That's also known by some within the hospital systems have to have community health assessments. Below that is Transformation Quality Strategy. Below that is Performance Improvement Projects. And below that is Incentive Measures. So if you kind of take your population statewide, community health assessments, regions, or specific populations, if you think about hospitals, transformation quality, Medicaid, performance improvement projects, specifics within Medicaid, specific projects, and then within that, incentive measures, specific conditions. Across all those, there's a measurement strategy, and underneath that, there should be a quality program foundation. Slide. This is a slide that I actually took from slides that we've had before, but this relates directly to what we have now. So this is current state. CCO accountability to OHA is our current process for CCO incentive measures. There's an annual assessment of CCO performance on selective measures. This is all for you all who are mostly CCOs and nothing new to you. Measures are selected by metrics and scoring. It's tied to bonus dollars and it's compared to annual performance prior baseline. So you all know that. Next slide. Here's our accountability to CMS. So basically the federal government, Center for Medicare and Medicaid Services. So what I have on the left is the 2017 to 2022 waiver that just ended as of September 30th. And what I have on the right is the recently approved waiver that was approved on September 28th. And here's what basically the left has the 33, what we call state plan measures that we are operating under. And what we are operating under until we negotiate with CMS the next quality strategy, which is what you're hearing about right now. So what we have on the right, we have the approved 1115 waiver as approved by CMS on September 28, 2022. You have the waiver presentation by Lisa Croix in October last QHOC. And several other CCO meetings. I think they went on, I don't know how many different meetings. CCO Ops, CCO CEO, and Medicaid Advisory Committee. I don't know how many different meetings. What's to be determined? When you heard some of those different meetings about the waiver, you heard that there are some additional policy areas still to be negotiated with CMS. So FYI, we're still not done yet with the negotiations with CMS. There's still an evaluation plan to be negotiated with CMS. There's still a monitoring plan to be negotiated with CMS. And then there's still measurement to assess quality to be negotiated with CMS. So even though there's still a waiver that has been approved and the standard terms and conditions, STPs, you can see that to be determined is still a laundry list of operational and implementation details. Next slide. Now I'm going to move into somewhat I kind of view. So this kind of sets the thinking of what quality means to, what quality means to at least me, and what quality means to some of the federal government. This hasn't necessarily changed to some of the conversations that I've been hearing with CMS and also where the agency and where CMS is going and what I believe the direction is happening. So this is kind of just building some of the foundation. And if you want to have some of the conversations of where the direction is going, this helps set that. Some of you have heard me, my background and trainings in federally qualified health centers. So HRSA Health is basically the federal government that oversees us and the QHOC. Quality improvement consists of systematic continuous action that leads to measurable improvements in healthcare service and health status of targeted patient groups. So if you were to Google, if you were to look at QI, QA, QC, or if you to Google QHOC, what you're going to see from CMS is you're going to see HRSA, you're going to see the long-term services, and you're not going to see a lot under each one of those definitions other than HRSA and long-term services and Medicare. The Medicaid shop isn't necessarily coming fully up to speed in these quality improvement definitions, and so that's why you'll see these definitions. QA refers to the broad definitions of evaluations aimed at compliance with minimum quality standards, and quality control is really looking at the individual steps within that process. Next slide. Compliance is meeting a regulatory standard or requirement or law. And methods of correction is corrective action plans or audits. Next slide. OHA quality activities, compliance, audits, corrective action plan, the loveliness of fraud, waste, and abuse, which I believe y'all had a conversation about that last month as well. Quality assurance or QA, external quality review, complaints and grievances, which you just kind of heard about, and hearings and appeals. QI, known as quality improvement, performance measures, and just general quality improvement training support, technical assistance. Next slide. This is a slide I like to show, which talks about just kind of the QA versus the QI. QI is looking at the whole system. QA is looking at a standard or just a part of one check of an action. Just a visual. Next slide. I call it I'm gonna call it the Godfather. You can call it the Science of Improvement, IHI, Institute for Health Improvement. The Science of Improvement is an applied science that emphasizes innovation, rapid cycle testing in the field, and spread in order to generate learning about changes. It is multidisciplinary, drawing on clinical science, system theory, psychology, statistics, and other fields. So, in other words, it actually is rooted in science. And for all those that know and practice quality improvement, taken from Deming, taken from Toyota, and applied in healthcare. Next slide. So now we're going to get a little bit into the quality strategy. Why does a quality strategy exist? And this isn't just kind of plain language. To provide a roadmap for direction and priorities for OHA, CCOs, and health systems for how to improve the care and access to OHP. Well, that's right. Number one, it's also federally required for managed care plans and for the state of Oregon. So there's actual federal code of federal regulations, otherwise known as CFRs. So in other words, we have to do it, but we should do it. So you don't just do it because you have to do it. Next slide. Here's the latest of the updates that have occurred in the Oregon quality strategy. So updates made in May 2021 were the most substantive. We updated to Oregon's 10-year goal and the actual health equity definition. So we also updated to the CCO 2.0 priorities, otherwise, known as your most current contract that you're operating under. We also include the state health improvement plan priorities or Healthier Oregon. We also updated to the MEGA rules, otherwise known as the Medicaid rules that were changed in 2018 that have been implemented through 2021. And then we updated it to the quality payment programs that exist across Medicaid, known as, there's a host of them, but and then we've made further refinements this last September, known as the Qualified Directed Payment Program, the QDPs that we talked about here at QHOC since April of this year. But we just made those final edits in September. Next slide. Here's some key requirements of a quality strategy. So if you don't want to fully read the Code of Federal Regulations around this, here's some key parts of it. It does need to include state goals and objectives. It needs to include measurements towards progress towards those goals and objectives. It does need to include a health disparities plan. Needs to be updated no less than every 3 years. It needs to be posted for public comment. And then once it's actually complete, it has to be posted on an actual public website. So those are the major components. There's other parts that have to be in there, but this is the key things. Next slide. I want to try and breeze through so we can get to some questions as well. This is a slide that I'm showing to kind of see some connection points. So let's I don't have like a wand. Like if I was in a room, I'd show you like how to, I'd have like a little pointer. On the left side, we'll go left to right. The left blue bar, OHA strategic goal, eliminate health disparity or with the North Star. If you go to the top in the green bar, Medicaid quality strategy, that's Oregon's Medicaid quality strategy. If you further go to the right, you see a purple, it says quality improvement strategy, QIS, for long-term support services. So that's our partners over in DHS, Oregon DHS. They have their own quality improvement strategy, in which we'll be connecting those pieces here, but it's connected through the 1915 waivers that we have. If we go back to the green box, within the Medicaid quality strategy, like I mentioned, we need to have goals and objectives. And within that, there should be some measures. If we stay within the goals and objectives box, underneath there, you'll see, I guess that's pentagons. Yeah, it's the pentagons. We have these levers of Medicaid. There's red, blue, yellow, and purple. There's waivers, QDPs, those are the qualified direct payment programs, and they're actually connected to the waivers. I don't have a connection dotted line, but they are. And then there's the SPOM, which stands for State Plan Amendment. And then there's the 1915 waivers for our DHS and other special populations over with long-term services, etc. So if we just stay in the waivers, the 1115 and the SUD waiver, basically what this is saying is under the waiver, you could have specific waiver goals, and under the QDP, you can have some specific QDP goals. And those have goals that need to be aligned to the overall Medicaid quality strategy goals and objectives. And within that waiver, you also will have waiver evaluation measures, and you'll have QDP evaluation measures. But those also need to align to your overall quality strategy goals and objectives. They may or may not be inclusive of your overall quality strategy goals and objectives, or they may or may not be specific to your QDP or waiver evaluation measures. Because basically in the green boxes, you might have things in there that align to your state health improvement plan or Healthier Oregon. You might have things that go across your whole Medicaid world that's not just of your transformational goals, which is what's in your waiver. And so that's what's in the green boxes. Things that go across your whole Medicaid program. And that's inclusive of what you can see in the green, where you have 1115, which is kind of your transformational things you're trying to put out there. There's SUD, then there's the QDP. So the things in green are supposed to go across everything, and they may or may not be inclusive in each individual one of those evaluation measures. So that's why there's those dotted lines. Ideally for synergy and not having multiple measures, but there would be dotted line versus no lines. Next slide. This is a snapshot of the table of contents. And then the hyperlink is under the 2022 version underneath the title. So when these slides get uploaded, you can just click the 2022 version and it will get you there, but you can also just honestly Google Oregon Medicaid Quality Strategy, Oregon OHA Medicaid Quality Strategy, it'll get you there. Next slide. Oregon goals, objectives, example. So this is taken from our 2022, September 2022 version. The format for goals, objectives, and measures that will be updated is in this view. It matches the direction from CMS that we've received. This current table, like I said, is from the 2022 quality strategy for the qualified direct payments. What is missing from this table, so I just want to expressly state this, because again, this is an example, is the paragraph that precedes this that says, this is not exhaustive of all measures that the state of Oregon is tracking. This is just the measures for the qualified direct payment program. And then I hyperlink to the other table for the 33 state plan measures. We will be updating the measures for this, for the state of Oregon into the format that looks similar to this under the goals and objectives as we go forward. But this is just an example. Next one. Our current quality goal strategies as they stand ensure quality and access to equity. Aligns to our 1115 waiver. Access to equitable. These align to our Healthier Oregon, again known as the SHIP, aligns to our 1115 waiver. And then what you'll see is we're trying to again have that synergy with our current other priorities within the agency. Ensure equality and access through equity, access to equitable, preventable healthcare, improve integration and care coordination, ensuring a skilled and educated health workforce with a cultural competency approach. Michelle, go back a slide, please. So what you'll see is if you look under, like, for instance, goal number 2, middle of the page, access to equitable, preventive health care. Under that, objective 2, ensuring appropriate care is delivered in an appropriate setting is objective 2. You'll see there's a third objective, improve the behavioral health system and address barriers to access and improve integration of care. You'll notice that's where the IET metric is listed. So you'll see kind of the work that we're doing now around IET statewide PIP or incentive measures is lined up under goal 2, objective 3. So hypothetically, well, not hypothetically, when we list our statewide PIP information, we'll say, you know, if I were to write this now, which I'm not, but if when it comes time for me to write our statewide PIP information, it will say lines up to goal 2, objective 3, because it's already listed here as part of our work related to behavioral health QDP application. Because again, looking for that alignment. Next slide. Next slide. Quality strategy. What's to come? So 2022 quality direct payment quality strategy updates, October. We have submitted those off to CMS. We will be making further updates to align with, like I said, the CMS toolkit and the most recently 1115 waiver. We will continue to work with CMS post a waiver approval and additional negotiations with approval. We will then again next year look for further refinements with the qualified direct payment program, and then start to look for alignment with that 1915 waiver as well. What that is that purple box, the quality improvement strategy with the long-term services. And then in 2024, look for alignment with the Health Equity Quality Metrics Committee that was approved with the waiver. So as that committee, I guess, is formed and then further develops its charter and course, then the quality strategy and measurement strategy will need to be updated and reconciled. All of this is obviously contingent as far as the timeline as the CMS negotiations continue. Next slide. So what's happening? So OHA Medicaid Quality Strategy Development Teams. I'm going to be working closely with Veronica Guerrera in the OHA Quality Assurance team on this, as well as with Stacy Schubert, Director of Analytics. We have a measure, obviously you can't have quality without measurement. So Stacy with Analytics, Quality Assurance team, and myself will be helping move this work off. So these development teams will start come together to work through alignment with the CMS toolkit, implementation, the waiver, and the QDP. So it's a lot of moving parts. Right now, we're constructing these teams around steering committee. So I'll just think about it like the executive committee. Current landscape, so assessing the current quality performance and gaps, clinical practice guidelines, transitions of care, otherwise known as care coordination, health equity, health disparities, and quality assurance. Pretty much the last 4 clinical practice guidelines, transitions of care, health equity, and quality assurance, those are pretty much directly referenced from the CMS quality toolkit. So CMS put out a quality strategy guidance toolkit. Those are pretty much the areas or things that are in said toolkit. Next slide. Partners in the strategy development. So we'll be going to the Medicaid, I have already started, as I did with the Qualified Direct Payment Program. But members will be in kind of throughout. So whether it's the Medicaid Advisory Committee, the Ombudsman's Office, the Complaints and Grievances Reviews, connecting in through other partners. Community-based organizations, we're going to be asking each one of those teams to check in and think through how they're going to connect into our communities. Our tribes, tribal consultation, community care organizations, that's you all. So we'll be doing regular updates and partnering here at the QHOC meetings. Hospitals, we regularly do that already through our qualified direct payment programs, but this is also another avenue. Providers, inclusive of QHOC, we're doing some outreach there. And then our ODHS through our long-term services. So we'll be connecting as well with our partners there. Next slide. This is what, as far as I think what will happen, this is with what I know of CMS. So we'll be convening the teams right now, actually, well, not right now, probably within this time of the holidays, lovely time to convene. We'll review the current state of what I know with where the waiver has been approved, what I know is in it, what's in the CFR, and where we are with our qualified direct payment negotiation with CMS. We'll assess the waiver requirements, just like I said, and that's all happening between now and the end of this calendar year. First quarter, start to look at some of the community feedback. I am going to the MAC, I already have, but we'll continue to reinforce that, start to get into the ONSPED schedule, and go into talking to the teams about how they want to go into the community. But we're working that with the rest of the waiver implementation. So we have a team implementation, so we're not doing anything separate from them. Start to think what if the goals that we have, do they need to be expanded, and then start to go from those goals into objectives. And then reach out to our tribal liaison and Julie Johnson, tribal director, and think through tribal consultation at what point when we have enough detail to go forth with that. And then in the next quarter, start with the updates. There's the next slide, please. The slide after that is just the resources. So question time. I left us a few minutes of questions. Oh yeah, the toolkit, the actual toolkit I referenced here, that's the actual CMS guidance toolkit. They are very, it says recommended. It is, I'm going to say recommended, but one of those recommended but required kind of things. I'm gonna get to your question, David, but I see Cynthia raised her hand first.
Yeah, hi there, Lisa. It's good to see you. I just wondered, there was a presentation at the Oregon Health Policy Board a couple weeks ago that had to do with some pretty disturbing outcomes. I don't remember hearing or seeing about those before. Is there going to be some type of a feedback loop to this group when quality scores or quality outcomes regarding specifically behavioral health are not meeting, the mark? It would seem that those should come back here. And I don't remember, I know I've missed a lot of meetings, but Laura, Dr. Burnett would have certainly gotten those back to me if they had been brought here. I guess that's a question and a comment.
I had actually missed that one.
Yeah, it was pretty disturbing, and I didn't see data sources. I didn't see.
Was it from a member or was it from an?
No,
OHA
this was
report?
Dave Inbody and Chris DeMars presented the.
Oh, I heard about that report. I was out with a migraine that day, Cynthia. Can you send me an email, please?
Yes, I can have Laura McKean. Laura, if you're on lines, please send that to Lisa and tell her where, instead of you having to listen to the whole 2.5 hours or whatever.
No, I don't even need to listen to it. What I need from whoever, well, Cynthia, you could honestly just send it to me and just say if you were on that call, whoever was on that call.
Okay.
So here's the connection point. This is the quality health outcome, and actually this, I'm just going to get on my little, so y'all need to be ready. When we do our 2023 planning next month, which it doesn't have to wait till next month, you can send an email, whatever. But when we do our planning about what and how we want this meeting to work through, because you all are the brain, you all are the quality brain, you all are the performance improvement brains. How that information to what Cynthia is saying is, hey, I heard something disturbing in another meeting that related directly to something how I could maybe influence or impact or do something about because I'm a quality brain, right? What and how do we get that information here? Because there's the policy side, right? That was the OHPB, Oregon Health Policy Board. But this is the quality realm, which is a different parts of a conversation. And I'm saying there's not a policy conversation that happened, but there's probably a quality conversation that happened, is what I hear Cynthia saying. We need to make those linkages. And that's all Cynthia's going to say is, write the email and I'll try and make the linkages. How we get the information in the right places to make said conversations to make things better for those people out in Oregon as I look outside my window. That's my job to help do. I can't be at 20,000 places at one time. That time I wanted to be there, but I had a migraine, so that didn't work. But that's exactly what we'll be having those discussions in our 2023 planning. But if we know of those things that say, hey, I heard this at OHPB or I heard this at the behavioral health meeting, that's how we should be spending our time in this in QHOC. Medical management in the morning is one thing. How and what we should be doing in the afternoon to drive the improvement in our members' lives is to what Cynthia's point is. And
well, I have another piece of my question.
Another conversation.
Does the behavioral health, is there ever a time like once a quarter or even a couple times a year where there's an integrated behavioral health meeting with this group and oral health? Just again, it goes back to those less than
we're gonna have to
desired.
figure that out since we have the IET one now. I mean, we're gonna have to.
Okay.
But they meet at the exact same time as us. And we did that, Cynthia, when we were meeting in person and everyone had to carpool together. So there was a reason behind it, in thinking through being good stewards of people's money, of carpooling money and driving together and all that. So that's why that's why, in essence, the people met at the same time, because a lot of people were convening in Salem at the same day.
Sure.
And so behavioral health meeting moved to the same day so that the CCOs were, the individuals were driving together to save on, you know, gas and such. But I think we're gonna have to think through, and those are the things that we can write down and try and think through as a chair group, as far as those operational details of next year. Like, I think we as a quality group need to meet quarterly with the behavioral health group, especially when we're trying to work through the SUD statewide PIP. You know, that should be an ask. If that's the group's consensus, then it's upon me and the behavioral health chair and the behavioral health staff to try and make that happen.
Yeah, I mean, the outcomes that were presented were just abysmal, and that also happened at the State of Reform during a breakout session. So it just makes sense that the quality group would at least help, I guess, look at the less than desirable outcomes since it's at a crisis level, and try to come up with, you know, collective impact interventions. I don't know how else to say it. But those are my thoughts, and I really appreciate you taking my question and hearing my comments today, because it does seem logical. But I do realize sometimes that logic is not playing into it, but I appreciate you hearing my concerns, and 2023 would be an opportunity is how I see it.
Well, you might want to make December so you can put it down, because hopefully I'll remember.
All right, thank you, Lisa.
Any other questions on the quality strategy, at least where the agency, so CMS, I believe ultimately, when they put out the quality strategy toolkit, which basically view it as your TQS guidance, right? Your TQS guidance document, CMS put out a toolkit to all states saying, thou shalt go put together your quality strategy. Here are some recommended guidance from CMS. And here's basically in that guidance requirements of what you should put in your strategy. And it tells every state, you need to do this, you need to do this, and you need to do this. And we recommend you do this, 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 and this. And in that guidance, they're pretty clear on where they're going, which is really a performance. I mean, it's really a quality improvement and a compliance. So that first slide where I set that foundation of compliance, you know, like, here's the rule, here's the policy, go do that. Check, check. And then here's where the performance is around performance measure, quality measure. That's pretty much what this toolkit is. So they pretty much went and got IHI, and IHI told them, here you go, here's how you do quality improvement. And that's the threads that you see throughout this toolkit. And then here's how you do compliance. And that's the toolkit. Go put this rule in, go put this rule in, check, check, check. And then have a performance measure, a goal objective to know where you're going. And that's pretty much throughout this toolkit. And that's pretty much where the state of Oregon has to go with their strategy. Well, recommended, not required yet, but pretty much on the wall, writings on the wall. So we're gonna go. Actually, we have to, because it says it in the waiver. So even though the toolkit says recommended, the waiver says, you know, otherwise.
Lisa, they've been a quiet bunch today.
I think it was just, I gave a very thorough overview, like David said. No.
I agree.
One of the things that people should be aware of is if I myself am reading what's coming and my head hurts, and it's not, then know that when I'll be coming back, most likely in January to you all, in a session as far as how these pieces connect. So I just gave you a big overview, but I'll be coming with you because you remember you're listed as a partner. And I'll be coming to the MAC and the onset, and I'll be coming saying, here is some of the measures, and you'll be like, Lisa, really? And I'll be like, this is what CMS is saying to me. And you'll be like, no, really? And I'll be like, yeah. This will be that conversation we'll have going pretty much back and forth, because the message is clear from CMS, and I'm just the conduit. Let's just put it that way. So. And you guys get to tell me how infeasible this is or isn't from the operational details. The members will tell me whether that actually what we're measuring is helpful or not. The tribes get to tell me whether it actually is measurable in their lives, but I'll have those questions for each audience when I present slates of topics. But I'm just unfortunately a messenger when I look through the waiver of what's coming out and the toolkit. But that's probably how it's going to play out in January through, my guess, April. And if there's a different way or method you all want me to deliver said message, let me know. Or let Laura know. And then she'll let me know. But my guess is that's how it's going to play out. Or I'm going to go win the Powerball again. One of the two. More than my $2 that I won last time. Everybody's so quiet. They just want to write the Oregon's quality strategy themselves. That's a no?
No.
I'm sure they do. I'm sure they do. I have no takers. Nobody here wants to do it. Nobody wants to become a contractor for us.
We can do a voluntold.
Anna Warner wants to. I'm just gonna start nominating people.
I'm gonna, I no. Anna talked in the last session. She's been good.
I
We can
had-
pick on her.
I had so many questions to help stave off the interpretive dance stage of our meeting today.
I'm just gonna nominate Krista Janice, Jennifer Jackson. No. HSAG is just like, Lisa's just gonna start throwing out names of people who's gonna, come join the fun.
Yeah.
Maybe I'll just go to California and right there. California's that. Theirs is gonna be just as fun. Well, then there won't, we don't need to, if there's no question. Michelle, have you already posted the slides in your wonderful self? Or are you gonna be posting them?
I will do them. I will get them posted right now. Do you want me, can I just post it, the slide deck separately, or do you want me to add it to the master
Please
slide
add it
deck?
so that it's not separate.
Yep, will do.
Thank
I'll do
you.
it right now.
Real question about health outcomes measurement and actual, David. Oh. I don't know. Do you want me to, David, can you email me that so I can just hit forward? Please. Thank you. And actually, Sarah Kleinschmidt, are you on the line? Can you just drop the metrics QA email into the chat string so David can email it to that one? I don't have it memorized. There's a metrics questions email. If not, David, just email me and I'll get it to the metrics questions. Because that's the one that a whole bunch of analytics people monitor, and then they tag the right individual. So David, get it to me and I'll get it to you, and I'll copy that email string, and then someone will get it to the right individual. Okay, well, everyone have a safe holiday next week, and Laura and the chairs will plan the December. Cynthia, I'll look for your email as we start to think about how to connect whatever information you heard at the OHPB this month, and then we'll also think about it from the macro view of 2023 planning. And then everyone else can look at the slides about what's coming for Oregon's Medicaid quality strategy, because ultimately that, all rolls down to how you all will be living your lives in the Medicaid plan life. So you can always email me later after you review the slides and go, Lisa, what the heck was that about? Y'all know I'm about a couple weeks behind on my email, but just know if there's something urgent, just ping me or text me. So I appreciate it. Thank you for hanging on till 2 o'clock. Everyone have a good rest of your afternoon.
Thank you, Lisa.
Thanks, Michelle. Bye.
Thank you.